مساء الخير. هنبدأ بإذن الله مع الدكتور مها جميعي، Associate Professor of Pathology كلية الطب جامعة الإسكندرية، عن a dose adjusted for oncology and breast cancer pathology. اتفضلي يا فندم.
هو في بوينتر اوكي هايل. مساء الخير. لازم اقف هنا. مساء الخير، انا اسمي مها جماعي، استاذ مساعد باثولوجي في جامعه اسكندريه وكونسلتنت هيستوباثولوجيست في بهيه. Today I'm going to present breast pathology that is necessary for any oncologist to know. Breast pathology is huge، فانا هحاول احطها في حته كبسوله صغيره كده تبقى يعني simple، واعذروني لو نزلت simple قوي عشان build upon that simple نوصل لل more complicated issues. دي الاجنده of what we are going to discuss، ودي ال famous slide بتاعت the breast cancer still remains the number one cause of cancer in females. لو نتكلم على الديث بينزل، لو بنحسب ميلز وفيميلز بينزل لنمبر 5، ولكن لو بنتكلم على females only it still is the number one cause of cancer related deaths in females. وده إن دل على شيء هيدل على إنه in spite of all the progress that we have made in early screening and diagnosis and in targeted therapy, we still have a lot to do. طب هدخل في الموضوع بقى على طول عشان الباثولوجي طويل وكتير. احنا basically we receive in the lab 3 أنواع من العينات. يا تبقى core biopsy which is the incisional biopsy، يعني بناخد حته من التيومر، او مشتقات الكور زي الفاكيوم اسيستد او اي incisional biopsy. الحاجه الثانيه اللي هي الاكسيجن biopsy that we remove the whole tumor whether just an excision or a wide local excision بmargins حواليه، and as you can see we ink the margins well، or الاكسيجن specimen تماما واللي هي الماستكتومي بكل انواعها. لما when we examine these specimens بنطلع بمعلومات مهمة that is going to appear on the report that you are receiving. أهم المعلومات دي بالذات من السبيسيمنز الصغيرة، الهيستولوجيك subtype، النوتنغهام جريد، الانسايتو component، presence of absence of angiolymphatic invasion and the biomarker status. كل ده بنعرفه لحتى من السبيسيمن الصغيرة الكور بايوبسي. When we receive the bigger specimen المعلومات بتزيد اللي احنا المفروض نحطها على الريبورت and will include the stage، the TNM being multicentric ولا لا، ال DCIS البرسنتج بتاعه بنقيسه في التيومر هو قد ايه، and we evaluate the response to treatment إذا العيانة أخده neoadjuvant chemotherapy. هاخدهم واحد واحد كده، مش هتكلم على كله بالتفصيل بس هاخدهم واحد واحد والحاجات المهمة والجديدة في كل حتة. الهيستولوجيكال سب تايب ما اتغيروش كتير قوي من ساعه ما احنا كنا بندرس طب في سنه ثالثه من 15 سنه 20 سنه مش فاكره كام. ما اتغيروش كتير، ولكن الليتست WHO شالت حاجات كتير قوي من اللي كانت محطوطه في السبيشال تايبس وحطتها اندر الانفيزيف بريست كارسينوما NST. فاحنا بيسكلي هنتكلم على الانفيزيف كارسينوما in most of our talk today. شالوا حاجات كتير قوي من الحاجات اللي كانت ليبيد ريتش وجلايكوجين ريتش وانكوسيتيك والكلام ده كله اتشال من انهم يبقوا سبيشال تايبس واتحطوا تحت what we call invasive breast carcinoma NST اللي هي بتظهر عندنا في الريبورتس ان بنقول عليها invasive duct carcinoma. هي دي الماجوريتي اوف ذا كيسز، 70 ل 80% of الحالات اللي بنشوفها fall under what the WHO requires ان هو اسمها invasive breast carcinoma NST. طبعا السبيشال تايبس اللي فاضلين في الكلاسيفيكيشن هم اللوبيولر والميوسينوس تيوبولر مايكرو بابيلاري. طبعا مفيش وقت ان انا اتكلم على كل واحد من دول بالتفصيل، هقول بس الحاجات الجديده شويه. الانفيزيف بريست كارسينوما NST زي ما احنا شايفين بتبريزنت with an irregular mass لونها ابيض، لها infiltrative border، وبنيجي على الهيستوباثولوجي لها جريدز كتير بتتراوح ما بين well differentiated moderately and poorly differentiated، والسيلز بتبقى infiltrating the surrounding and eliciting what we call a desmoplastic reaction حواليها. desmoplastic reaction يعني fibrosis الدسمو، فبالتالي بيتحول البريست فات اللي السيلز عماله تمشي فيه ده الى fibrous tissue more dense، فات appears ليا في الماموجرام على حاجه more dense لونها وايت اكتر بسبب الدسموبلاجيا اللي حاصله دي. These tumors 65% منهم بيبقوا ER positive، 20% بيبقوا HER2 negative، و15% بيبقوا triple negative. والنسب دي برضو مهمة for the auditing of the practice في أي معمل، مهمة قوي برضو النسب دي إنها تفضل consistent with the published data. اللي عايزه اقوله انه لا خلينا زي ما قلت ان في حاجات كتير قوي من الحاجات اللي كانت special types now is considered as part of the IBC NST، ومن ضمنها النوع ده اللي كنا بنسميه زمان medullary carcinoma او carcinoma having medullary features، اتشالت دي من السبيشال تايبس وبقت في WHO الجديده بنقول عليها IBC NST with a medullary pattern، ما بنقولش عليها medullary carcinoma anymore لان هي it's overlapping مع some basal-like اللي هنتكلم عليه في الآخر اللي هو من التريبل نيجاتيف كانسرز. يعني إيه medullary features؟ يعني tumor is well circumscribed، عنده very high histologic grade، السيلز شكلها وحش قوي، عاملين زي سنسيتيوم، يعني كلهم عايمين في سيتوبلازم كده مش باين السيل بوردرز بتاعتهم. أهم حاجة فيه عنده a very rich tumor infiltrating lymphocyte infiltrate، وده معناه ايه؟ معناه ان البودي is eliciting a strong immune response against these tumors، وبالتالي this explains why these tumors have a better outcome عن a similar stage IBC NST عادية. و definitely these tumors are usually triple negative tumors، وده مهم برضو جدا لانه الكونكوردنس ما بين الهيستولوجي والبيولوجيكال او البايوماركر ستاتس حاجه مهمه جدا. يعني لو لقيت تيومر عنده الميدالري فيتشرز بس لقيته طالع لي اي ار بوزيتيف، اشك شويه واعيدها احسن عشان these tumors are usually a big percentage of these tumors is triple negative tumors. other special types مش هتكلم عليهم بالتفاصيل، اللي هو invasive lobular نفس الكلام ما اتغيرش كتير عن الحاجات اللي موجوده في older classifications. It is usually again an ER positive tumor. other tumors اللي هي mucinous والtubular again they are always، او مش قادره اقول always لان لسه شايفين حاله ER negative قريب. most commonly they are ER positive، وبرضه برجع يعني أأكد على حتة الكونكوردنس ما بين الهيستولوجي of the tumor والبايوماركر ستاتس بتاع التيومر ده. يعني لسه حتى عايزه اقول انه كان عندنا حاله قريب mucinous carcinoma they always tend to be ER positive، لما لقيناها ER negative عدناها مره واثنين وثلاثه عشان نتاكد انه ما فيش حاجه غلط في البروسيجر في الكنترول because these tumors tend to be yes there are cases that can be ER negative بس الماجوريتي از ER positive، فالكونكوردنس ده لازم يبقى دايما في دماغنا ما بين الهيستولوجي والمولكيولر ماركر. التاني حاجه في الريبورت از ذا جريدنج، ما اتغيرش كتير، ده نوتنغهام جريدنج ما اتغيرش كتير على اللي بنقوله زمان. التيوبيول فورميشن، النيوكلير سايز بليومورفيزم والميتوتيك كاونت. الحاجه اللي جديده مش جديده بس حاجه اللي مهمه في الميتوتيك كاونت، اذا كان في حد باثولوجيست هنا سمعني، ان احنا مش لازم نعد في 10 هاي باور فيلدز، احنا بنعد في مساحه 2 ملم سكويرد، والمساحه دي بتختلف من ميكروسكوب للتاني، فكل باثولوجيست لازم يحسب هم المساحه دي عنده في ميكروسكوب وهو كام فيلد، عشان الرقم ده بيفرق قوي. يحط الحاله من 2 ل 3 تفرق لي قوي في الجنرال جريد، لان احنا وي اد دي سكورز. المينيمم سكور از 1 و1 1 يبقى 3، واللارجست سكور از 3 و3 و3 يبقوا 9. الانسايتو كومبوننت، كلمة in situ يعني tumors that موجودة inside the ducts inside the acini and they have not crossed the basement membrane. معنى كده ايه؟ ان they do not have access لا للليمفاتكس ولا للبلاد فيسلز، وبالتالي they cannot metastasize. مش هنلاقي lymph node metastasis مع حالة in situ بس. لو لقيت lymph node metastasis والريبورت طالع لي in situ بس يبقى في حاجة، يا اما they did not dissect الجروس specimen كويس and they need to go and do regrossing. Usually this is what we do. لو حالة لقينا in situ بس ولقينا lymph node we do grossing and regrossing and regrossing لحد ما نلاقي this invasive focus اللي سبب الميتاستاسيس. زمان كنا بس بنحتاج نقول ال in situ ده شكله ايه، whether it's solid ولا في كوميدو ولا كريبريفورم ولا papillary او مايكرو papillary. دلوقتي لازم نديله جريد، لازم نقول هو low grade, intermediate grade or high grade، لازم ندي جريد للانسايتو. لو مش متاكدين whether these masses are actually in situ ولا هم tumor masses جوه في وسط الستروما بتاعه البريست، we do what we call myoepithelial markers بالimmunohistochemistry، واللي عاملينه هنا هو cytokeratin 5-6 to delineate المايوابيثيليال cells حوالين الducts. الحاجة الثانية that the WHO recommends إنه all DCIS tumors لازم نعمل لهم ER مش PR. PR is optional بس لازم يتعمل لهم ER. 75% of these tumors are positive for ER. اللوبيلر كارسينوما ان سايتو دي حاجه مش جديده بس عايزه اقولها it is not considered a TIS زي ما الدكتال كارسينوما in situ is considered DIS. lobular carcinoma in situ is no longer a malignant disease. It does not require staging. ما بنقولش عليها TIS. It is just a risk factor that tells ان الست دي has a high risk من 8 ل 10 times risk of developing breast cancer whether ductal or lobular in any of the two breasts مش بس في البريست اللي هو فيه ال LCIS and it does not require resection, does not require safety margins. الحاجة المهمة قوي واللي أخده يعني اهتمام كبير في the latest years are the tumor infiltrating lymphocytes. والtumor infiltrating lymphocytes are the lymphocytes in the stroma inside the tumor. برضه عشان لو في حد من الباثولوجيست سامعني بنعد الليمفوسايتس مش في الستروما اللي حوالين التيومر، بنعد الليمفوسايتس في الستروما اللي جوه التيومر و it should be reported as a percentage. يعني percentage من الستروما مش من the whole size of the tumor. يعني الستروما مساحتها تقريبا 2 أو 3 سكوير مليمتر، نصهم فيه lymphocytes، يبقى أنا بقول الtumor infiltrating lymphocytes are 50%. فبنعدها as a percentage of only the stromal component والستروما اللي جوه التيومر مش اللي حوالين التيومر. ده معناه ايه برضو التيومر infiltrating lymphocytes كل ما زادت كل ما معناه ان البودي is eliciting an immune response against the tumor. معنى ان في immune response ان البروجنوزس هتبقى احسن، ان الاوتكم هيبقى احسن لان عندي immune response against the tumors وسيلز موجوده جوه التيومر بتعمل بتهاجم التيومر سيلز. كميه التيومر انفلتريتنج lymphocytes ان كل ما بيزيدوا كل بيحصل better outcome. This is especially important في حالات التريبل نيجاتيف والهيرتو بوزيتيف. It is very very important ان كبروجنوستيكلي ان انا اعرف فيها تيومر انفلتريتنج lymphocytes قد ايه لان it has a big prognostic significance. اخر حاجه واللي انا عايزه بقى اخد وقتي فيها شويه لما بجري علشان خاطر اوصل للجزء ده البايو ماركر ستاتس. وده زي ما بقول كل الريبورتس بتطلع بالبايو ماركر ستاتس بتاعها، حتى الكور بايوبسي ما بينفعش تطلع غير لازم يكون معاها البايو ماركرز بتاعتها. فاول بايو ماركر هنتكلم عليه و is the estrogen receptor. والايستروجين ريسبتورز والبروجسترون ريسبتورز دول ريسبتورز موجودين جوه النيوكليوس، وبالتالي احنا لما بنسبخهم وبندور عليهم بدور زي ما انا شايفه هنا كده على الصوره دي على نقط بني. معنى كده ان النيوكليوس ده فيه ريسبتور للايستروجين. النورمال بريست تيشو فيه ريسبتورز، فالنورمال بريست كان بي يوزد از ا بوزيتيف كنترول. وانا ببص على السلايد بتاعتي فلو لقيت النورمال بريست اللي جنب التيومر مش واخد اصلا نيوكليير ستيننج يبقى معنى كده ان في مشكله عندي في البروسيس. I have to repeat or find another find the problem in my procedure. فاللي كان قبل كده بيتقال انه مجرد وجود 1% of the tumor cells expressing ال ER ده معناه this is a positive tumor and it will respond to endocrine therapy. فعندنا يا اللي على الشمال خالص اللي هو ال completely positive اللي هو ER positive مليان، وفي طرق كتيرة لل evaluation of the ER positivity whether بنقول +1 +2 +3 أو بنستخدم ال all red scoring أو ال H scoring. كلها different scoring systems بتقول لي هو قد إيه في ER positivity، أو إن ما عنديش خالص less than 1% وده اللي بعتبره negative. الليتست في الليتست WHO بتقول إن في category في النص اسمها low positive ER. اللو positive ER ده معناه ان السيلز expressing the ER are only من 1 ل 10%، فدي بنسميها low positive. طب اهميتها ايه؟ ان احنا مش متاكدين yes انه there are data بتقول انه they are eligible for endocrine therapy بس their behavior is more like the ER negative. فالbehavior بتاع اللو positive ده انا ما اتوقعش ان هو هيبيهيف like the normal hormone receptor positive tumor. It will most likely behave that شبه اكتر molecularly شبه وفي البيهيفير بتاعه شبه ال ER negative tumors. البي ار ما فيش كلام كتير عليه غير انه هو في الكلاسيفيكيشنز المولكيولر كلاسيفيكيشنز بتاعت البريست كانسر when it is negative بيحول لي البريست كانسر ده من luminal A لليومينال B. فit has a prognostic significance ومش very well validated in terms of predicting response to chemotherapy to endocrine therapy. الحاجة الثانية إن its use في ال DCIS is optional. مع DCIS الجايد لاينز بتقول إن لازم نعمل ER بس مش لازم نصبغ بالبي ار. ده برضو الستين it's a nuclear stain فبنشوفه زي دوتس بني staining the nuclei of the cells. وده الجزء في الكلاسيفيكيشن اللي بيقول لي إن في نوعين من اليومينال بي. لو البي ار نيجاتيف ده بيخليها اليومينال بي مش اليومينال اي. هنتكلم عن الكلاسيفيكيشن دي كمان شويه. الثيرد بايوماركر is the HER2 وبرضه كلام هنا مفيش حاجات كتير جديده، في حاجات جديده in terms of therapy بس مفيش كلام جديد بالنسبه للباثولوجي. لو there is incomplete staining بالاول انه الHER2 ده membrane receptor يعني موجود على السيل membrane and it responds to growth factor stimulation. لما العيانه بيبقى عندها جين amplification اللي هو على الكروموزوم نمبر 17 لما الجين بيبقى amplified بيبقى فيه اوفر اكسبريشن للبروتين على السيرفيس وبالتالي this بروتين بيعمل الفانكشن بتاعه من غير ما حاجه تمسك فيه. يوجوالي الريسبتور بيستنى لما الجروث فاكتور يمسك فيه فيعمل its function in terms of increasing the proliferation السرفايفل بتاع tumor cells. هنا because of the الامبليفيكيشن اللي حاصله في الجين والجين ميوتيشن هو بيرسبوند لوحده من غير ما يبقى عنده جروث فاكتور فالسيل عماله تبروليفريت تديفايد. بنحسبه ازاي احنا في الباثولوجي؟ لو هو incomplete staining of the membrane ده بيخليه على طول نيجاتيف. لو عندي complete staining او اقل من 10% complete staining of اكتر من 10% بس very weak انا بارلي شايفاه يا دوبك لازم انزل للفيري هاي باور عشان اشوفه ده اللي بيبقى البلس 1 اللي هو ده. لو واضح جدا ومحوط السيل كلها و very very clear strong staining in more than 10% of the cells this is a +3 ده it's eligible for the HER2 targeted therapy. لو احنا في النص اللي هو ما بين ده وده intermediate staining يبقى this is the +2 this is the equivocal category اللي انا الاميونوهيستوكيمستري هنا مش مساعدني محتاجه resort to more sophisticated techniques اعمل له فيش اعمل له سيش according to the lab that you are dealing with بيعملوا ايه. Now في بهية we do SISH and it's very very well done in بهية. The fourth biomarker is the Ki-67 وال Ki-67 has not been universally used ولا advised to use في recent years عشان the lack of consensus about ايه اللي نقول عليه هاي وايه اللي نقول عليه لو. قعدوا سنين بيقولوا طب 14 15 دلوقتي في 20 في حاجات بتقول 5. there is lack of consensus about احنا هنقول على مين هاي ولا لو ولاck of consensus كمان احنا هنعد ازاي. يعني في ناس بتعد بعينيها وعشان نعد بعينينا it's a very very tedious process لازم اعد كام number of cell is positive وكام number of cell حواليها واخد percentage في كام field واعمل average. ف it's a very very tedious process to do it with the eye but we actually do it او بنعمله بالimage analysis. فال lack of standardization of how we do it بيخليه مش popular قوي. However in the recent years with the latest guidelines بقى في كلام كتير قوي عليه على ان احنا لازم هنعمله في اوقات كتير. الcommon in the ER positive tumors they tend to have a low KI. ال KI is a proliferation marker, a marker ان السيل دي عماله تديفايد بسرعه. ال ER positive tumor they tend to be low in KI. ال ER negative tumors وال HER2 positive tumors they tend to have a higher KI usually 30% فما فوق. ال ER positive tumor فيهم wide range of ممكن يبقوا high وممكن يبقوا low بس دايما اغلب الوقت بيبقوا على اللو سايد. recently بقى في النيور guidelines بتاعت ال WHO بيقولوا ان ال ER positive tumors HER2 negative اللي عندهم node positivity لو ال KI بتاعهم اكتر من 20 وحطوا 20% دي they can be eligible ان هم ياخدوا cyclin dependent kinase inhibitors. ما كانش في الكلام ده قبل كده. this is the late ده 2021 data. الحاجة التانية اللي بنستخدم فيها ال KI برضو is حاجة اسمها ال IHC4 وال IHC4 ده an assay of 4 biomarkers اللي هم ال ER وال PR وال HER2 وال KI. بنستخدمهم وندخل الداتا بتاعتهم على فورمولا كده تطلع لي الريسك اوف ريكورنس او الريسك اوف ميتاستاسيس في العينه دي زي اللي هو الماما برنت وال 21 جين وال 70 جين اسي اللي بيقولوا لي العينه دي هيحصل لها ريكورنس ولا مش هيحصل لها وبيست اون ذات بقرر ان انا هديها كيمو مع الاندوكراين لو هي HER2 بوزيتيف ولا مش هديها. ف one of those assays اللي هو ال IHC4 it's an immunohistochemistry based assay بس كمان بيطلع لي prediction of من ضمن الحاجات اللي موجوده في الاسي is the Ki-67. ال PD-L1 وزي ما اتكلمنا على التيومر infiltrating lymphocytes ال PD-L1 is a very very important marker nowadays to test for in particularly in triple negative breast cancers. زي ما اتقال في معظم المحاضرات كل ال other tumors ال ER positive وال HER2 عندنا options كتير انما ال triple negative ما عندناش options كتير نديها له غير الكيموثيرابي. فلما ظهر ال PD-L1 ده ال PD-L1 ده عباره عن ايه؟ ده ال PD-1 is a receptor موجود على السيرفيس of the lymphocyte. الليمفوسايت اللي هي قلنا عليها اتكلمنا عليها من شويه اللي هي بتبقى موجوده في الستروما بتاعه التيومر البي دي 1 ده if stimulated يعني لو مسك فيه اللايجند بتاعه هيinhibit the function of this immune cell وبالتالي the anti-tumor immune response اللي المفروض يحصل بيختفي. فبيعمل بيقلل البودي immunity against the tumor, the body immune response against the tumor. اللي احنا بنعمله ايه؟ ان احنا بندي ادويه to block this pathway, to block the pathway لان tumor cells can express ال PDL1 اللي هو اللايجند اللي بيمسك في الريسبتور ده. فبالتالي لو التيومر عنده البي دي ال1 هيمسك في البي دي 1 ويقلل الانتي تيومر اميون ريسبونس. الادويه اللي احنا بنعملها بتارجت الباثوي ده وبتinhibit the interaction of the PD1 with the PDL1 on the surface of the tumor. ف بتimprove البودي اميون ريسبونس against the tumor. طب احنا كباثولوجيست بنعمل فيه ايه او بنقيسه ازاي؟ الاول كنا بنقول ان any staining more than 1% whether of the tumor cells or the immune cells is considered positive. دلوقتي بنعمل له حاجه اسمها combined positivity score. الcombined positivity score ده اللي هو number of the PDL1 positive cells على number of the total number of viable cells اللي موجوده بنعد طبعا في كذا high power field ونضربها في 100. لو السكور ده اكتر من او يساوي 10 معنى كده ان this patient will benefit from the PDL1 targeted therapy. اخر بايو ماركر ومعليهوش كلام كتير قوي ولسه still under clinical trials is the androgen receptor. ولسه it's not currently requested as a standard practice however بيبقى used ساعات في حالات التريبل نيجاتيف breast cancer وكمان في حالات الاي ار بوزيتيف. هعديه بس عشان عايزه اوصل لدي انه breast cancer is a very 1 minute بس. breast cancer is a very ممكن نخليها بس it's just 1 minute. Breast cancer is a very heterogeneous disease at the molecular level, so it's more than one disease, it's not just one. Well, there has been several attempts at classifying breast cancer molecularly in the recent years. أكتر حاجة مستخدمة لأن هي أكتر حاجة مش مكلفة ووايد سبريد في كل اللابز هي الاميونوهيستوكيمستري. فبنستخدم الاميونوهيستوكيمستري بالأربعة ماركرز اللي احنا قلنا عليهم ER, PR, HER2, KI عشان أقسمه كلاسيفيكيشن بتاع اليومينال A اليومينال B النوعين بتوع اليومينال B والهيرتو بوزيتيف والتريبل نيجاتيف. في حاجه تانية شبه الكلاسيفيكيشن دي بتتعمل بحاجه اسمها البام 50 اتس ان RT-PCR based assay بيقسمهم لي نفس التقسيمه it is more sophisticated more accurate بس بيقسمهم لي basically نفس التقسيمه اليومينال A اليومينال B HER2 enriched وبيقسم التريبل نيجاتيف لبعض الانواع. الحاجه الاهم الاكتر بقى لسه ما فيها مش موجوده في معظم اللابز and it's more definitely more expensive is the genomic and the transcriptomic analysis اللي بيقسمهم لي انتو clusters 10 clusters اللي هو 1 و2 و3 و6 و7 و8 دول they correspond للاي ار بوزيتيف بتاع الكلاسيفيكيشن العاديه. نمره 10 ده اللي هو الاي ار نيجاتيف اللي هو التريبل نيجاتيف اللي هو more genetically unstable and more aggressive disease. واللي في النص اللي هي 4 دول التيومرز اللي عندهم هاي تيومر انفلتريتنج ليمفوسايتس. وبرده الترانسكريبتوميك اناليسيس بتقسم لي التريبل نيجاتيف جواها الى 4 انواع بيزل لايك 1 بيزل لايك 2 ميزنكيمال اند ليومينال اي ار بوزيتيف. أنا كده وصلت لآخر حاجة و what I want to say from here إنه breast cancer is very heterogeneous. It is not one disease, so one size fit all does not exist. The lack of concordance ما بين الهيستولوجي والstatus بتاع البيولوجيكال markers ده you should raise questions and should urge us to confirm our results and our data. The early stage node negative tumors has very good prognosis almost قريب جدا من النورمال population وبالتالي the role of screening is very important. آخر حاجة عايزة أقولها in spite of this great advantage that we have achieved we still have a lot to do. Thank you very much.
شكرا جزيلا دكتورة مها. We'll proceed to the second speaker. Dr. Rasha Kamal will present diagnostic approach to some common clinical scenarios. دكتور رشا اتفضلي.
لا انا بقى عشان مش شايفه حاجه ان شاء الله مش بحرك من هنا عادي خلاص طب بسم الله الرحمن الرحيم. the diagnostic workup of some common clinical scenarios. لا مش هشوف. لا إن شاء الله لا إن شاء الله. In breast imaging, it is challenging enough to be able to diagnose the underlying cause behind breast symptoms. Yet the biggest challenge is how to apply the best practice to do so. Usually, the breast imaging cycle starts with the patient, whether symptomatic or asymptomatic. The patient is referred to the clinician who orders a specific imaging. He refers the patient to the radiologist who approves or disapproves this imaging modality. And he writes the report and he gives the report back to the patient. Normally, this breast imaging cycle should go on smoothly, but sometimes it becomes interrupted when the clinicians asks for a wrong examination or when the radiologists ask for accessory, unnecessary imaging. And usually this occurs because of the miscommunication between the radiologists and the clinician. When we had only mammography and ultrasound in hand, things were easy. Where an asymptomatic patient is referred for regular screening mammography, and she might need further ultrasound examination or intervention. A symptomatic patient, we look at her age. If she's below 40, pregnant or lactating, we usually start with an ultrasound examination. And if she's above 40, we start with a mammography examination. And in either cases, we might recommend for the other modality. And we might further proceed to further intervention. But now we are having more and more imaging modalities. With the mammography, we have the tomosynthesis, the contrast mammography, and the PET mammography. With the ultrasound, we have the Doppler, the ABIS, and the elastography. And with MRI, we have more sequences like the diffusion and spectroscopy. And I think looking at this, we have to admit that the volume of breast imaging modalities have grown exponentially, and thus implementing sound practice has become a real challenge. And in this lecture today, we are going to understand how we can incorporate the modern breast imaging modalities in the diagnostic workup of some challenging common clinical scenarios. As I understand, this lecture is meant for young oncologists, so I'm going to give a brief definition of these modalities to enable you to understand how we use it in the diagnostic workup. For the mammogram, the patient is usually imaged in the upright position. The breast is usually placed between a compression plate and the detector. And the breast, we usually take the breast in two views. The standard views are the craniocaudal and the mediolateral oblique view. Unfortunately, although we depend mainly on mammography in screening and even in the diagnostic context, it's always accused of having a low sensitivity because the normal breast tissues may give the impression may obscure an abnormality, and this is responsible for a large number of false negative results. It's also accused of having a low specificity because the superimposed breast tissues might give the impression of a false abnormality, which is responsible for a large number of false positive results. And that's why we see every day technical developments on the mammography. And I will show you one example which shows really how mammography can be deficient. This was a young female. She had a heterogeneous dense breast parenchyma, and in spite of the fact that on the ultrasound we see a multicentric carcinoma, we can hardly detect this carcinoma on the mammogram. We might suspect some areas, but we will never be sure without a complementary ultrasound. And the first technical advancement to mammography was the addition of the 3D digital tomosynthesis. The 3D digital tomosynthesis is simply a mammogram. Again, the breast is placed here between the compression plate and the digital detector. What's different from a mammogram is that in mammography, we just adjust the tube, and then we take an on, and we turn the tube to a certain angle, and then we take the other on, which gives us the CC and the mediolateral oblique views. But in tomosynthesis, it's not like this. We place the patient as if we're going to have a CC view, and the X-ray tube moves in an arc across the breast, taking a series of low-dose images. The total dose of this is equivalent to or slightly higher than a single-view mammogram. Looking at the breast from different directions will give us a 3D reconstructed image, which can be viewed after every 1 millimeter, exactly like what we do in CT. In CT, we take the patient as a volume, but when you see the CT images, you see them as slices, as if you are passing by cuts within the patient himself. And that's what we really do. And by doing this, we solve the problem of overlapping and superimposed breast tissues. Imagine that I have in a breast 3 lesions that are adjacent to each other or overlapping to each other, microcalcifications, an area of distortion, and a speculated mass lesion. If I just place the breast like what we do in a mammogram, I will see the 3 lesions overlapping each other, and I would not be able to identify or to characterize any of these lesions. While if we do the tomosynthesis and we go slice by slice within the breast, a slice will pass through the calcification, another slice through the distortion, and another slice through the speculated mass lesion, and by this I can characterize each lesion independent of the other. We usually have many tomosynthesis slices. We look at all slices carefully, and then we choose the slices where the lesions are more apparent. We look at these slices and we start to characterize the lesions with no overlapping tissues hiding the lesion. Tomosynthesis detects actually more cancers even in a fatty breast. This is one example. She has an ACR A to B, which is a predominantly fatty breast. She had this lesion in the right breast, which was misinterpreted by a radiologist as an intramammary lymph node. We did tomosynthesis, and look how it is different on tomosynthesis, removing all the overlapping tissues. We can now see that this is not an intramammary lymph node, and it is a small speculated mass lesion, and it was in a fatty breast, not in a dense breast. We might think, but by removing the overlapping tissues, that we have solved all the problems of mammography. But actually, the best imaging modalities are those which can give us morphology and enhance morphology assessment, and in the same time, it supplies us with some functional information. And this we get through the contrast injection, like what we do in contrast mammography and MRI. Tomosynthesis only gives us an enhanced morphology assessment, but it doesn't give us any functional information. And that's why another addition was added to the mammogram, depending on the process of angiogenesis. The tumor cells, as they grow, they secrete a pro-angiogenic factor that stimulates the proliferation of new blood vessels and new capillaries to supply the tumor cells with oxygen and nutrients. These blood vessels are not well formed, and they allow for leakage of the contrast media in the surrounding tissues. And that's why when we have malignant lesions, they enhance more than the normal surrounding parenchyma. And that's what we depend on in MRI and contrast mammography. Both contrast mammography and MRI have features in common. In both modalities, we inject contrast media in order to highlight areas of concern within the breast. But the way we do this is different in MRI than it is in contrast mammography. In MRI, we take a series of pre-contrast images and the post-contrast images. We subtract both from each other, and then we get a subtracted image where the only outstanding feature in the image is the enhancing mass lesion. In contrast mammography, it's not the same. Both images are taken after contrast injection. The first image, we call it a low energy image. It's similar to a mammogram exactly, and we use it actually when doing the contrast mammography as a mammogram in which we characterize lesions on a mammogram. And then we take a high energy image, and this is not a diagnostic image, but it is used to, when we combine the low energy and the high energy image, we get what is known as the recombined, or we used to call it a subtracted image, in which everything in the breast is cancelled except for the enhancing lesion. This is an example which will show you that we use tomosynthesis and still we needed to perform a contrast mammography for this patient. She was a 35-year-old female with a palpable left breast mass lesion. Corresponding to the area of clinical concern, there was this speculated mass lesion. We performed a tomosynthesis, and on tomosynthesis, the lesion appeared more speculated, and it appeared more like a mass lesion than just a focal asymmetry. We thought that the problem has stopped here, but unfortunately, during her ultrasound examination, we identified a tiny lesion in the right retroareolar region. When we went back to the mammogram and the contrast mammography, we were not sure where this lesion was. While looking simply on her contrast mammogram, the lesion was here. It was a tiny lesion in the retroareolar region, and it was proved to be an invasive duct carcinoma. And even look at the breast, the left breast lesion, it was not a single mass. It was a multifocal mass lesion with a wider extension than what we saw on the mammogram and the tomosynthesis. Now we'll go back to our diagnostic or challenging common clinical scenarios, and the first scenario is screening. And I always tell them that in screening, we follow the traffic lights, where we classify the female population into an average risk population with no specific risk of developing breast cancer, and this includes most of the female population. We have a group which is classified as the moderate risk. They have a risk from 15 to 20% higher than the general population. And the third group, which is known as the high-risk individuals, they have a risk which is higher than 20% than the general population. For the average and most of the moderate risk individuals, we do a screening mammogram, which might be complemented with an ultrasound examination starting the age of 40 years. For high-risk individuals and selected moderate-risk individuals, we do a mammogram at an earlier age. It's not only complemented by an ultrasound, but it should be complemented with an MRI as well. If we have 3D digital tomosynthesis, it must be applied in either the CC or the mediolateral oblique view, because using tomosynthesis, we will detect more cancers, and we'll have less cases will be recalled. Contrast mammography, I think in the future it will enter in the screening programs, but up till now it is not validated that we can use it in screening. This is an asymptomatic woman. She came for her annual screening mammogram. We suspected the presence of subtle microcalcifications in the left breast. This was the tomosynthesis of the same patient, and as we see, we can now see that this microcalcification is a suspicious group of microcalcification. And we did an ultrasound, an underlying hypoechoic lesion was identified. It was biopsied, and it turned out to be an invasive duct carcinoma. This is another case. It's breast density classified as an ACRD. We thought first that it was a normal dense breast, but when we did the tomosynthesis, going through the slices, in one slice we identified this subtle spiculated mass lesion, and again it turned out to be an invasive duct carcinoma. This is another high-risk individual. She has a heterogeneously dense breast, and this is common with high-risk individuals. She had multiple areas of concern within both breasts, which is the true area of concern, is only seen on the contrast mammogram, where she had a multifocal carcinoma in the left breast. This is another screening mammogram of a 50-year-old female high-risk individual. She had newly developed microcalcifications within the left breast. An MRI was requested and revealed focal non-mass enhancement, but the time signal intensity curve was type 1, which is a benign, continuously rising curve. A biopsy was taken, and this was a case of an atypical ductal hyperplasia. We now move to the second station, which is pain or mastalgia. Mastalgia is a common symptom experienced by up to 80% of women at some point in their lives. The age at which the patient presents with mastalgia is of major concern. Mastalgia is classified into either non-cyclic or cyclic, focal or diffuse. For non-cyclic focal mastalgia, further imaging is appropriate to exclude underlying pathology, while for cyclic diffuse mastalgia, further imaging other than regular screening is inappropriate. Mammography is often used to evaluate breast pain, and in most cases, no imaging correlate is found to explain the cause of this pain. And when clinicians insist on imaging evaluation of breast pain in the presence of negative clinical examination, this increases unnecessary additional imaging studies. And this case is one good example to prove what I was just saying. She's a 35-year-old female with cyclic mastalgia, more on the left side. On examination, nothing was palpable. On her mammogram, she had a subtle asymmetry or an area of increased density in the left breast. On ultrasound, it was simply underlying focal fibroglandular tissue, and she had non-specific lymph nodes. The report was that she had focal adenosis in the left breast. Her clinician was worried, and so he insisted that he wants to do a contrast mammogram, and it's normal that areas with increased fibroglandular tissue would take a contrast uptake. And that's what happened on the contrast mammogram, and he insisted on a biopsy, and the biopsy came back again with focal adenosis. On the other hand, some patients, they should be imaged, but they are neglected, like this 28-year-old female with fibrocystic mammary changes, and she said she has history of cyclic mastalgia. But she developed right focal mastalgia on top that was neglected for 6 months. This was her ultrasound examination. She had multiple cysts in the left breast, but within these cysts, we had multiple solid mass lesions. So directly we recommended for a contrast mammogram. And as we see here on the contrast mammogram, there was a diffuse infiltrative lesion on the right side. And on the left side, there was also another carcinoma in the upper outer quadrant. The third station is the palpable mass lesions. A palpable breast mass is one of the most frequently encountered clinical complaints, and it is one of the commonest presenting features of breast carcinoma. When we have a palpable breast mass, we start by looking at the age of the patient, above 40 years or below 40 years, or if she's pregnant or lactating. Above 40 years, like what we said before, start with a mammogram. It might be complemented with ultrasound, MRI, or contrast mammography, or biopsy. Below 40 years, we should start with an ultrasound. It might be complemented with a mammogram, MRI, or a biopsy. But usually no additional imaging is needed other than sonomammography. This is a 45-year-old female with multiple palpable breast lesions. This is her mammogram. She had multiple lesions in the left breast, and this was the contrast mammography. The first mass was not non-enhancing, and anything which does not enhance on contrast mammography is 99% benign, and this was actually a fibroadenoma. The other lesion was an enhancing mass lesion. If you want to describe it, we will say it's oval or rounded, non-circumscribed, showing homogeneous enhancement, and it was associated with pathological axillary lymph nodes and microcalcifications, all points pointing to a malignant diagnosis. If we go back to her ultrasound examination, we will find that we had these features on the ultrasound without a need to perform the contrast mammography. This was the pathological axillary lymph nodes. This was the malignant enhancing lesions, and we can see the microcalcifications. And this was the fibroadenoma. So we could have solved this case with the mammography and complementary ultrasound without the need to a contrast mammogram. The last station is the nipple discharge. Nipple discharge is also a common clinical complaint. It might be physiologic or pathologic. Physiologic nipple discharge is usually bilateral, multi-orificial, occurs on squeezing the breast. It is milky, green, or yellow, and may accompany duct ectasia, mammary adenosis, or some inflammatory lesions. Pathologic nipple discharge is usually unilateral, uni-orificial, spontaneous. It is usually bloody, and it accompanies intraductal papillomas, periductal mastitis, and some malignant breast lesions. So the first step when we have nipple discharge, we should examine the nipple discharge and decide whether it is physiologic or pathologic. For physiologic nipple discharge, no specific imaging is needed unless she is valid for regular screening if applicable to the patient. For pathologic nipple discharge, we start with a sonomammography, and only if negative should we proceed to MRI, contrast mammography, or cytology. This is a 30-year-old female with history of duct excision. Now she is complaining of bleeding per left nipple. As we see here on the mammogram, there is a segmental microcalcification. This was her contrast mammogram, and in this case, the contrast mammogram was not performed to diagnose, but to identify the true extension of the lesion for the surgeon to make his decision. And it was a case of DCIS. This is another case with uni-orificial bleeding per left nipple. We see that we had left breast nodular lesions, and the contrast mammogram was performed. But if you ask me, I would tell you that she did not need this contrast mammogram, because what we see on the mammogram is the same as what we saw on the contrast mammogram. We have multiple lesions, but we cannot localize or characterize. Look at her ultrasound examination. That we see dilated ducts with intraductal papillomas. Actually, ultrasound is the best in whenever we have physiologic nipple discharge, because it diagnoses simple ductectasia, ductectasia with retained secretions, and with secondary periductal mastitis. It can also diagnose clearly intraductal papillary lesions and intraductal papillary carcinomas as well. So to put things together for modern diagnostic workup, and we classify patients into asymptomatic who would perform screening mammography. If we have 3D tomosynthesis added to your mammogram, it increases detection and decreases recall rate, and ultrasound is sometimes requested, especially when we have dense breast, for better characterization. And MR is requested for high-risk individuals. For symptomatic patients, we either start with ultrasound or mammography according to the age. Usually they are enough. Ultrasound is the best in intraductal lesions and mastitis. Contrast mammography and MRI are necessary for multiplicity, multifocality, and extent of occult disease. Definitely, in the last decade, we have witnessed an intense increase in the volume of breast imaging techniques with the development of new technologies and the upgraded application of already existing ones. These new breast imaging technologies are meant to enhance the evaluation of patients with breast problems by ruling out the presence of breast cancer and in the same time addressing the patient's symptom. Yet the challenge will always remain: how can we achieve this goal by using the right modality in the right time and for the right person? And thank you.
Professor Dr. Rasha, thank you. Now we are going to present Principle of Chemotherapy by our dear Professor Abdelhamid Fouad. أهو اللي بيشاور.
طب احنا ممكن اقول لها هي تستأذن واللي عايز يبارك لها بره.
حلو قوي البوينت ده. مساء الخير جميعا. Thank you, Chairman. I would like to thank the organizing committee for inviting me for this talk. We will discuss today the principles of cancer chemotherapy. I am Abdelhamid Fouad. I'm a lecturer in the Medical Oncology Department, National Cancer Institute, Cairo University. This is my agenda. We will discuss the kinetic basis of drug therapy, chemotherapy drug classes, principles of combination chemotherapy, factors of effective cancer chemotherapy, mode of action of cancer chemotherapy, mechanism of resistance, and toxicity profiles. Before going to the kinetic basis, we have to have a look on the cell cycle. For any cancer cell that will undergo division, it needs to enter the cell cycle that start by the G1 phase, where the cell grows and accumulate essential proteins, and as DNA binding blocks, it takes about 6 to 12 hours. Then followed by the S phase, where there is DNA synthesis. Cells start to replicate chromosomal DNA and result in pairs of chromatids. It takes about 6 to 8 hours. This is followed by the G2 phase, which is a final preparation before the M phase or mitosis. where the cell provide energy and synthesize essential proteins needed for the mitosis phase. And at last, the mitotic phase, where the nucleus divide and the chromatids separate from each other, and giving two cells at the end of the cell cycle. Based on growth pattern, tumor cells are classified into terminal differentiated cells that have no capabilities of proliferation, and resting cells or G0 cells that can go for terminal differentiation or enter the cell cycle, and proliferating cell that is cycling in the cell cycle. And the growth fraction for any tumor cell is the proportion of actively proliferating cells cycling in the cell cycle. And chemotherapeutic agents mainly target these proliferating cells. So, in a fast-growing tumors like lymphomas, especially Burkitt's lymphoma, where the tumor volume can double in only one day, chemotherapy here is very active because these tumors has high growth fraction. On the other hand, slowly growing tumors like lung adenocarcinoma, the tumor volume need about 80 to 90 days to double. And here chemotherapy alone is not enough, and usually we need other treatment strategies like radiotherapy or surgery to control the disease. But normal cells that are rapidly dividing, especially bone marrow cells and the cells of the GI, are also affected by chemotherapeutic agents, and these lead to the most common side effects seen with the use of chemotherapy. Chemotherapeutic drugs are classified based on their chemical properties or mechanism of action, source, natural or artificial, and propensity to cell cycle, being cell cycle specific or non-specific, or cell cycle phase specific or cell cycle phase non-specific. When talking about the chemical probabilities, classes of chemotherapy include alkylating agents, for example, cyclophosphamide, cisplatin, and platinum analogs like cisplatin, carboplatin, oxali, antimetabolites, methotrexate, fluorouracil, and others, topoisomerase interactive agents like epipodophil toxins, anti-tumor antibiotics like anthracyclines, and the family of microtubule agents like vinca alkaloids and taxanes. And there is miscellaneous drugs like bleomycin, actinomycin, and some enzymes like L-asperginase. This cartoon showed the action site of different classes of chemotherapeutic agents, and they attack the dividing cell in the cell cycle at different levels. Like antimetabolites lead to inhibition of DNA synthesis, alkylating agent lead to damage of DNA, interlacing agents inhibit DNA transcription and duplication, and spindle poisons like taxanes inhibit mitosis. Chemotherapeutic drugs are classified based on the action on the tumor cells, to cells cycle specific and non-specific. Cell cycle specific, they kill cells that actively cycle in the cell cycle. They only act on certain phases of the cell cycle, and this means that the more rapid cell turnover, the more effective they are. And the dose response curve of this class follow the initially exponential. Their effect increase while increasing the dose by time, but at certain level, higher doses, maximum response is reached. On the other hand, cell cycle non-specific, they attack resting cells and actively cycling cells. The dose response follow the first order kinetics, where with increasing the dose, the more cells are killing by time. And also cycle-specific are classified into phase-specific and phase non-specific. Phase-specific means that they act on specific phases of the cell cycle. As we mentioned, the cycles of the cell cycle, G1 S phase, G2 and M phase. While cell cycle phase non-specific, they attack the cycling cells throughout the cell cycle, and the most famous example is the alkylating agent phase non-specific. This cartoon also shows the different action site of cancer chemotherapy at the level of cell cycle. Principles of combination chemotherapy: when combining different chemotherapeutic drugs in a special disease entity, both drugs should have some requirements. Each drug should have a single agent activity in that tumor type, no overlapping toxicity, no cross resistance. They should have different mechanism of action, should work in different parts of the cell cycle, and should respect also the therapeutic index, which is the ratio of the toxic dose to the effective dose, and optimal dose balance tumor versus host toxicity to have the maximum benefit from the combination and least toxicities. The principle of our idea of induction or neoadjuvant chemotherapy, which is the chemotherapy used before surgery or radiotherapy. It promotes regression of tumor cells, enhance local regional control via sensitization, lead to eradication of micrometastasis, and hence reducing distant failure rates. Identify the subtype of patient that can be treated by more conservative surgical approach, and identify the subtype of patients that may benefit from adjuvant chemotherapy. And this takes us to the adjuvant chemotherapy. It means the extension of chemotherapy treatment for patients who remain at high risk of recurrence after primary tumor and all evidence of cancer have been surgically eradicated or removed or treated by definitive radiotherapy. Concurrent chemoradiotherapy, this term used preliminary in patients who have unresectable disease to improve local regional control. Interaction between the chemotherapy and the radiation results in synergistic enhancement of the treatment outcomes. And this mechanism of interaction is comes through increase the initial radiation damage, inhibition of cellular repair of malignant cells, cell cycle effect as elimination of radio-resistant S-phase cells, and arrest of in radio-sensitive G2 and M phase. They also this combination also countering the radio-resistance by decreasing the hypoxic cells by eradication of hypoxic cells, and the increased tumor oxygenation through increase the cell loss. And also they overcoming accelerated repopulation of the malignant cells. Then we will go for two factors affecting cancer chemotherapy. We have three main factors affecting cancer chemotherapy: tumor factors like tumor grade, tumor type, stage, chemosensitivity; drug factors that include transport defect for the tumor, for the drugs, improved DNA repair inside the malignant cells, amplification of some genes that lead to cells resistant to drugs. And patient factors like age, performance status, presence of comorbidities, immunological function, emotional factors, and socioeconomic factor in the patient treated with cancer chemotherapy. We will take some ideas about mode of action of cancer chemotherapy. We will start by alkylating agent family. It includes different chemotherapeutic drugs here in this slide, and they act by the polyfunctional compounds. Their cytotoxicity results from alkylation of guanine at N7 position, and this interferes with DNA replication, transcription to RNA. Also, cross-linking of DNA and ring cleavage may also occur. And as we mentioned, alkylating agents are the most famous cell cycle phase non-specific. Antimetabolites include folic acid analogs, purine analogs, pyrimidine analogs like methotrexate, fluorouracil, famous examples. They replace metabolites in the key DNA, RNA replication molecules, leading to impairment function inside the malignant cells. They compete with metabolites at the catalytic sites and regulatory sites of the key enzymes. The platinum compounds are tetravalent heavy metal platinum that binds to two potentially leaving groups, the chloride groups. These two chloride groups. This binding is loose, and they undergo slow displacement with water, especially in the environment where the chloride is in low concentration, as inside the cells or in urine. This leads to positively charged aquatic complex, resulting in bifunctional covalent links analogs like alkylating reaction. The topoisomerase interactive agents include anti-tumor antibodies, anthracyclines, epipodophyllitoxin, camptothecins, and others. The mechanism of interlacing agents, they have planar region that stuck between the base pair in the DNA, forming tight drug DNA interaction. This affects the structure of DNA, preventing the polymerase and other proteins from binding to DNA and lead to cell death. The plant alkaloids include different subtypes like vinca alkaloids, podophyllitoxins, camptothecins, and taxanes. We will take some example. Vinca alkaloids inhibit microtubule spindle, lead to arrest in mitosis phase, and taxane through enhancement of tubulin polymerization. Podophyllitoxin, it's a topoisomerase 2 inhibitor, block cells in the late S and G2 phase, result in DNA damage through strand breakage induced by the formation of a complex by the drug DNA and the enzyme. Camptothecin is a topoisomerase 1 inhibitor, result in DNA damage. And the taxanes, as we mentioned, it acts through enhancement of tubulin polymerization. Mechanism of resistance of cancer chemotherapy, it may be due to intrinsic factors like lower doses given to the patient, improper scheduling of the chemotherapeutic drugs, inadequate delivery of drugs like in sensory sites like testicular masses, CNS diseases, or genetic mutation that occurs or epigenetic mechanism. And also the resistance to chemotherapy may be due to acquired resistance in the drug, like decreased import of chemotherapy inside the cells, increased export by the malignant cells, or decreased activation of the drug inside the cells, or increased inactivation. And also may be due to acquired changes in the target cells, like amplification of some mutations, altered mutation, or increased DNA repair. We will move quickly to the toxicity profile of cancer chemotherapy. Different cancer chemotherapies have different toxicity profiles, including alopecia, mucositis, nausea, vomiting, diarrhea, cystitis, pulmonary toxicity, cardiotoxicity, hepatotoxicity, nephrotoxicity. Adverse effects may occur immediately, hours to days after chemotherapy infusion, especially extravasation, emesis, hypersensitivity, tumor lysis, or may occur early after days to weeks after chemotherapy infusion, like myelosuppression, mucositis, alopecia, cystitis. May be delayed, occurs weeks to months after chemotherapy, like lung toxicity, cardiotoxicity, and may be late, like second malignancies, teratogenicity, sterility. Classification: chemotherapeutic side effects are classified based on its reversible or irreversible. Irreversible like bone marrow suppression, alopecia, hyperpigmentation, and irreversible like cardiotoxicity, especially for regarding anthracycline cardiotoxicity, hepatotoxicity, ototoxicity, especially for platinums. Maybe direct or indirect. Direct like bone marrow suppression, indirect like increased rate of infection secondary to bone marrow suppression, and may be classified based on the group or class of chemotherapy, like special complication related to alkylating agent or antimetabolites or other subtypes, or classified based on the systems like CNS toxicity, nephrotoxicity, or GI toxicity. We will have some ideas about the induced organ-specific side effects. We will start by nausea and vomiting. It may be anticipatory. That means that the patient has nausea and vomiting before receiving chemotherapy, and it's mainly related to his fear from the side effects. Acute emesis that occur within 16 to 24 hours after infusion of chemotherapy, and delayed vomiting that occurs after more than 24 hours. And based on emetic risk of chemotherapeutic agents, they are classified to high risk that occur mainly in all patients, especially cisplatin, high dose of cyclophosphamide above 1.5 gram. Moderate risk occur in more than 30% of patients. low risk that occur in 10 to 30% of patients, or minimal risk, less than 10% of risk to develop emesis. Cardiotoxicity may be acute or chronic. Acute like ECG changes, and usually it is reversible and insignificant, and maybe it is serious like acute pericarditis, myocarditis syndrome that may occur 1 to 2 days after anthracycline administration. Chronic side effect, the most famous example is chronic anthracycline-induced cardiotoxicity, and it is characterized by myocardial dysfunction and congestive heart failure. It is irreversible, and risk of cardiotoxicity increase with history of chest radiotherapy, administration of other agents, especially cyclophosphamide and trastuzumab, pre-existing heart disease, female, and starting treatment, female gender, and starting treatment in young age. Exceeding the cumulative dose of anthracyclines above the cumulative dose dramatically increases the probability of developing congestive heart failure, and this graph show after exceeding the cumulative dose of anthracycline, of doxorubicin, the risk increased dramatically, and also ibuprofen, when exceeding the cumulative dose, the probability increased dramatically. How to prevent? Use do not exceed the cumulative dose. Use liposomal formulas of anthracyclines. Use in some cases cardioprotective agents. Cytotoxic drug that cause nephrotoxicity. Some drugs have high potential, especially platinum, methotrexate. Others have occasional and irreversible nephrotoxicity. Sometimes we have azotemia without nephrotoxicity. Other drugs have effect on bladder, like hemorrhagic cystitis, especially ifosfamide or high dose of cyclophosphamide. Risk factors for nephrotoxicity increased in elderly underlying kidney disease or tumor-related kidney effects like direct renal involvement by the malignant tumor itself, like myeloma kidney, infiltration by lymphoma cells, or indirect effect involvement on the kidney like true volume depletion by dehydration caused by nausea, vomiting, diarrhea, effective volume depletion in patient with cardiomyopathy, ascites, pleural effusion, or metabolic effect as hyperuricemia and hypercalcemia. Or some drugs have a higher risk by itself, innate drug toxicity, higher doses of exposure, some drugs result in insoluble drug or metabolite forming crystals that lead to nephrotoxicity, or concomitant use of some drugs like non-steroidal or aminoglycoside that increase the risk of nephrotoxicity. Hepatotoxicity, these some drugs that have hepatotoxicity effect. Risk factor for hepatotoxicity increase in patients with pre-existing liver disease, hepatobiliary tumor involvement, immunosuppressed patient with viral hepatitis, nutritional deficiencies, or use of parenteral nutrition. Patient clinical presentation of patient with hepatotoxicity may be asymptomatic with just increase in liver functions, or acute illness like jaundice resembling viral hepatitis. Some drugs cause chronic inflammatory changes. Some drugs have reversible toxicity, and others have irreversible toxicity with progression to liver fibrosis and cirrhosis. Neurotoxicity, this is drugs, example for drugs with neurotoxicity. They affect the CNS from central till the peripheral nerves. Pulmonary toxicity, risk increase with patient advanced age, oxygen therapy, simultaneous or prior radiotherapy to the chest. Can I have 2 minutes, please? Or I have to stop? Sure, thank you. Pre-existing pulmonary disease. Examples for lung toxicity: pulmonary edema, interstitial lung disease, lung hemorrhage, gonadal toxicity, secondary malignancy, hypersensitivity reaction, may be early or late, hyperpigmentation, usually reversible, hyperpigmentation, extravasation, drugs are classified to vesicant, irritant, non-vesicant, according to their effect on tissues. Vesicant is drugs that are capable of forming blister, tissue destruction, and need sometimes skin grafting. Irritant make discomfort. Extravasation is an important side effect, need management. Management is to stop administration, withdraw 5 milliliter of blood, infuse steroids around the site of extravasation, compression, and sometimes use an antidote. Alopecia, nerve dystrophy, nail dystrophies, pictures. Hand and foot syndrome is a common complication. It's a skin lesion begin by erythema, edema in the palm and sole, and may progress to desquamation. Management is using thusing creams, pyridoxine, dose delay reductions. In some aggressive forms, discontinuation is needed. This is the grading, and thank you.
Thank you so much, Dr. Abdelhamid. Now with Dr. Shaimaa Lashin.
هيبان okay, thank you. Well, first of all, I would like to thank Bahia team very much for extending this very nice invitation for me to be here with you. I'm here for the first time. Hopefully I will be a light guest. And my talk today is about principles of endocrinal and target therapy in breast cancer. A very big topic, but let's go back to the basics and build upon what we already know and how to correlate that with what we see in the clinic. And this is especially dedicated for the young oncologists. I hope the more senior oncologists will not be very bored. First of all, some facts and figures, and you have heard this in previous sessions. You know, breast cancer is the most common cancer. The last statistics, now breast cancer is the most common not only in females, but worldwide. Despite that, it's the second leading cause of death, not the first, as a somewhat green light. And among breast cancer cases, most of the cases are those cases that express hormone receptors. Hormone receptor positive breast cancer constitutes about 2/3 of the cases of breast cancer. So most of your patients, or at least 2/3 of your patients, you will manipulate endocrinal treatment, and that's why you have to have very good understanding of the estrogen receptor pathway and of how we do things in endocrinal manipulations. So this is the evolving landscape of what we have for endocrinal treatment for breast cancer. Of course, we have our very old friend, the tamoxifen. The tamoxifen is our first player. And then we have the aromatase inhibitors, and this is what we have for early breast cancer. Thereafter, we had the fulvestrant, and in metastatic breast cancer, we will speak about each in details. Starting 2012, we started to see combinations of target therapy with endocrinal treatments to overcome the somehow inevitable incidence of resistance to endocrinal treatment that we see in most of the patients. Okay, this is the breast cancer, the estrogen receptor signaling pathway. Basically, this is the estrogen receptor. This is the ligand. This is what activates the pathway. The estrogen gets into the cell, and the receptor is cytoplasmic. It's inside the cell. After ligand binding to the receptor, like just any receptor, the receptor dimerizes and then gets inside the nucleus and binds to what is called estrogen receptor elements. Bringing forth co-activators that will enhance transcription of several downstream genes responsible for cell cycle proliferation and evasion of apoptosis, angiogenesis, a lot of downstream signaling after estrogen receptor signaling. Okay, I have this pathway on the side because I just want to remind you that all of the time, it's not only as simple as this. We have other pathways, signaling pathways that interfere with the AR signaling pathway, like the PI3K, AKT-mTOR pathway, for example. There is always some sort of crosstalk, and that's why we always know that there are several mechanisms that may show resistance later on. I will start with the basic. And we'll start with the normal estrogen receptor pathway. And just to remind you, where does estrogen come from? Estrogen comes from testosterone and androgen by aromatization and conversion into estrone or estradiol, E1 or E2, which in turn co-convert. Okay, you cannot work with hormonal treatment without knowing the definition of menopause. And despite of how clear it seems or how easy it seems, I actually see a lot of juniors making this mistake. Okay, دايما هنعتبر ان a patient is premenopausal. Okay, it's a confirmation if the patient is young and has regular menses. But the fact is, basically a patient is premenopausal until postmenopause. So البينة دايما اني اثبت المنopause مش العكس. Okay, so we have some criteria امتى اقول البيشنت دي menopausal. First things first, by age above 60. Above 60 is a menopausal patient. Okay, هو المنopause عموما it's an event that happens between 45 and 55 years of age تقريبا. يمكن في مصر يكون بيحصل earlier شوية. Okay, the other thing is if a patient tells you أنا عندي amenorrhea for more than 12 months, but please remember that this has certain conditions. العيانة لازم تكون بقى لها 12 months amenorrheic, and during these whole 12 months she has never received chemo nor tamoxifen or nor any other endocrine manipulation أو مثلا LHRH agonist أكيد. Okay, and despite that, you should confirm menopausal status by doing a lipid profile, a hormonal profile, FSH, LH, and E2. The last thing, if the patient is amenorrheic but is receiving one of the treatments اللي احنا قلناها, يبقى أكيد دول أولى إن احنا نعملهم FSH, LH, and E2. You have to be, and معلش, I will go back, and this has to be on serial assessments ليه؟ لأن some patients might go into very low levels of estrogen after receiving chemotherapy, for example, and then they have a resurge. والأشهر من كده aromatase inhibitors. Aromatase inhibitors sometimes لو العيانة still not into real menopause, they will induce her to go back into premenopause, believe it or not. فمش one reading. It's not one reading. You have to do serials, and usually I do monthly for at least 3 months. وبعد كده ممكن every 6 months لو العيانة صغيرة شوية, I would like to go and look back at things. Okay, well, please remember ده شكل how complicated it is. ده ال FSH, ال E2 بينزل definitely بعد المنopause. That's the E2 and that's what we can measure. Okay, ال FSH بيsurge بس الحقيقة later on it goes back down. Well, LH it's the same. You maybe at first testing you should look at the 3 combined لأنه ساعات الأرقام بتلخبط شوية. لكن later on you can depend on the E2 for serial looking back. طيب ده اسمه natural menopause. طيب في حاجة في النص, مش في النص قوي, هي الحقيقة menopause اسمها artificial menopause. في patient المفروض كانت تبقى premenopausal but now she's postmenopausal either because I intervened surgically, عملت bilateral salpingo-oophorectomy مش hysterectomy, لا bilateral salpingo-oophorectomy. في patients كتير بيعملوا hysterectomy just for fibroid مثلا, you have to ascertain. تاني حاجة by radiotherapy اللي هو ovarian ablation, I think you all know. وثالث حاجة medical ovarian function suppression اللي هو mainly ال LHRH analogs اللي بنديها. الحقيقة the last one is the only reversible one, ودي الميزة اللي فيه. لو أنا at any point احتمال أقول للpatient دي yes you can resume your menses and it's totally safe. لكن if I want the surest method for ovarian function suppression, it's the first method. Once the patient comes out from surgery, she's menopausal. You can start your treatment. Okay. طيب please 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 ما فيش patient بتاخد any form of ovarian function suppression اللي هم ال LHRHs يعني بيتعمل لها FSH و E2. You can never assign a menopausal status لعيانة بتاخد ovarian function suppression. There's no such thing. ما ينفعش أقول هي بقى لها سنتين وبقى عندها 53 سنة and I presume that she's postmenopausal. I have to stop. ولما stop I have to do serial testing again عشان أتأكد. Okay. I have to go very fast. طيب, how can I target the estrogen receptor pathway? الحقيقة in early breast cancer we have 2 ways to target. Either target the receptor أو target the ligand اللي بيمسك في الريسبتور. Okay? To target the receptor هي عندنا the very old friend tamoxifen. Tamoxifen بيمسك في الريسبتور. الحقيقه التاموكسين مش بينهبت الريسبتور, عشان كده هو اسمه SERM selective estrogen receptor modulator, لان هو بيمسك في الريسبتور والريسبتور بيدايمرايز and it continues its pathway بس only blocking the AF2 function of the receptor, بينما ال AF1 function شغال. يعني هو ليه agonistic part و antagonistic action. Okay, and this is very important to understand لانه side effects والactions كلها معتمده على الحته دي. I use the antagonistic part على البريست. اوكي, ودايما ببقى عيني خايفه من الاجونستيك بارت على الاندوميتريوم. I think you all know, عشان كده بنعمل السيريال transvaginal ultrasounds. We also have the agonistic part على البون. That's why we don't need to do DEXA scans وان انا ادي bone modifying agents في عيانه post menopausal under tamoxifen. بينما الهوت فلاشز والثرومبوإمبوليك events والstrokes and so on اكتر مع التاموكسفين. حته صغيره ورموها بعدين. One of the ways that a cancer cell can develop resistance للتاموكسفين هي القصه دي، اللعب في الاجونستيك antagonistic action by altering the expression of الactivators والسبريسورز. اوكي، دي حاجه peculiar شويه للتاموكسفين. طيب السيرم ينفع انا استخدمه في البريمونوبوزل؟ اكيد ينفع. ينفع استخدمه في البوست مونوبوزل؟ اكيد ينفع. it's a player all the way. عندنا evidence دي اوكسفورد ميتا اناليسيس. طبعا اللي خدوا تاموكسفين فيرسس ما خدوش، طبعا ده قديمه، بس فيرسس اللي ما خدوش لحد 5 years and later on الكيرفز بتبعد for recurrence and for mortality. طيب عندنا manipulation تاني ممكن اعمله بالتاموكسفين. ممكن لو العينه ستيل بريمونوبوزل اديها حاجه اسمها extended تاموكسفين بدل 5 سنين I can go up to 10 years. ما بنعملهاش كتير بس it's there. تاني طريقه let's go up ونشتغل على اللايجند. I will deprive the receptor from what activates it اللي هو الاستروجين. And this is we do through aromatase inhibitors. مش هو الانزيم اللي بيطلع الاستروجين at the end هو الاروماتيز. Let's go and play over the aromatase enzyme. And الاروماتيز انزيم الحقيقه موجود اكتر حاجه في الاوفري، عشان كده البريمونوبوزلز عندهم high levels of estrogen. But we still have aromatization بنسميه peripheral aromatization في كل الاديبوز تيشو، كل السبكيوتينيوس فات، في البون، علشان كده بيحصل لهم بون ريزوربشن قوي لما بعمل استروجين ديبريفيشن بالاروماتيز انهبيتورز. وفي البريست والبريست تيومرز most breast tumors they produce their own estrogen remember through aromatase. يبقى انا هشتغل by inhibiting الاروماتيز enzyme. ولما حملنا نعمل كده في البريمونوبوزل لقينا ان احنا مش بنقدر نعمل full aromatase inhibition، بنعمل only partial suppression. ف it ends up انه لسه في the whole axis is working بس انا قللت الاستروجين شويه، فحصل back pressure يعني back signaling انه actually there is increased production of estrogen. يعني انت لو اديت aromatase inhibitor في peripheral الاستروجين ده هيعلى. اوكي، بالتالي بما انه قلت كده يبقى ينفع ندي aromatase inhibitors للبريمونوبوزال patient؟ ما ينفعش. اوكي، طيب عندنا two families of aromatase inhibitors. non-steroidal اللي بنسميهم reversible، steroidal permanent. ما عندناش فرق كتير في الاستخدام ولا في الداتا، مقارنات اللي بينهم قليله وما طلعتش فرق. اوكي، طيب بالنسبه للسايد افكتس انا جبت لكم دي من one of the trials. السايد افكتس اللي اكتر مع الاروماتيز انهبيتورز كونسيرد للتاموكسفين هم الماسلر سكيلتال ديس اوردرز والارثرالجياز اكيد، والعيانين اللي عندهم ارثرايتس بيتعبوا جدا طبعا. الفراكتشر ريسك وده مهم، عشان كده we always give bone modifying agents. والاسكيميك disorders، لكن اقل في الحاجات اللي بيعملها التاموكسفين. برضو حته صغيره and you can throw it away. هنا في very peculiar mechanism of resistance بيذكر دايما مع الاروماتيز inhibitors. الريسبتور at a point لو حصل resistance it might go okay you are not giving me my ligand to hell with you I don't need the ligand anymore I will self activate. يعني انا مش محتاج استروجين anymore، انا كريسبتور هشتغل لوحدي. هو ده الاي اس ار 1 ميوتيشن بيتقال كتير. والاي اس ار 1 ميوتيشن عمره تقريبا ما بنشوفه في ايرلي، مفيش عيانه متشخصه وجايه من الشارع عندها اي اس ار 1 ميوتيشن. اتس ا سكندري ميوتيشن، هو ميوتيشن من الميوتيشنز اللي الكانسر بيعملها to adapt and to overcome the aromatase inhibitor. زي ما قلنا طبعا ما اقدرش استخدمه في premenopausal it's only for postmenopausals. benefit برضه في الاوكسفورد جايد لاينز سوري في الاوكسفورد ميتا اناليسيس فور ريكارنس، بس ما كانش في فرق في الاوفرول سرفايفل. لو حد يحب يجو باك انا بحط الاروماتيز انهبيتور ازاي وانا بعالج، الحقيقه وي هاف سيفرال استراتيجيز. يا اما دي اب فرونت كل العلاج يبقى بي اي، يا نعمل سويتشنج، اغلبنا بنعمل السويتشنج سنتين وثلاثه 3 و2، او نكستند ادجوفنت بعد 5 سنين بقت مينوبوزال طب احطها على اكستندد ادجوفنت اي اي. ودي اسامي الترايلز for whoever wants to go back. طب لو انا عندي عينه بريمونوبوزال وعايزه اديها اي اي you have to put her into the artificial menopause category. وطبعا اكتر طريقه بنستخدمها هي ال HRH out of ان هي دي الطريقه الوحيده reversible، ودي عينه غالبا you do not want to do permanent ovarian function suppression. However if you discuss with the patient and she wants to it's okay. طيب that's what we have for early breast cancer. في الميتاستاتيك breast cancer we have other players. عندنا one player كمان بيشتغل في نفس الباثواي وبيشتغل على الريسبتور اللي هم السيردز السيلكتيف ايستروجين ريسبتور داون ريجوليتورز. عندنا منهم اللي دلوقتي موجود في الفيسترين Fulvestrant بيعمل ايه different from tamoxifen. Fulvestrant binds to the receptor. It binds to the estrogen receptor and it deactivates the receptor. مفيش dimerization، كل اللي بعد كده بيقف، وبالتالي receptor is downgraded، يعني downregulated، يعني بيتكسر لأنه it does not doing its function. من هنا المفروض نتوقع انه superior للتاموكسفين، وهنا ملوش اي agonistic activity. It's mainly antagonistic. الفالفسترين ليه قصه لازم نبقى عارفينها، قصه لها عبره وعظه. الفالفسترين قعد سنين struggling and not getting into practice لانه كنا بنستخدمه بدوز 250 مللي جرام، وفي يوم من الايام اكتشفوا ان 250 مللي جرام is not enough. They went to 500 milligrams وعملوا كمان loading dose 500 every 2 weeks وبعد كده 500 every month. وفعلا الترايل دي بينت ده، هنا انا بقارن دوايه بدوايه at another dose. It was positive improvement في overall survival, progression free survival، وبقت approved dose for fulvestrant هي 500 and that's what we can use. وعندنا داتا عليه في second في beyond first line وفي first line في حاجه اسمها الفالكون trial. ادي فالفسترنت ولا ادي واحد من الاي ايز؟ عندنا داتا بتقول ان فالفسترنت superior شويه في البروجريشن فري سرفايفل، بالذات لو البيشنت عندها بون اونلي ديزيز. في الفيسرال ديزيز ما كانتش الاستفاده قوي. لحد هنا وقف القصه ان انا ادي سنجل ايجنت اندوكراينال تريتمنتس. وبقى في الميتاستاتيك باثويز، ميتاستاتيك بريست كانسر عندنا combination of target therapies with endocrine treatments. عندنا 3 اللي هنتكلم بس عن الحاجات اللي approved. 3 انا قلت البي اي 3 كي اي كي تي ام تور باثواي ده مهم قوي، لانه الباثواي ده احنا لقينا انه 40% من حالات الهرمون ريسبتور بريست كانسر عندهم الميوتيشن ده من الاول. اوكي، من الاول، مش زي الاي اس ار 1، ده ميوتيشن موجود من الاول and it's a source of resistance. و ما كانش عندنا ليه target therapies، دلوقتي عندنا. او go downstream قوي 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 واشتغل على السيل سايكل اللي هي at the end of the day chemotherapy بيشتغل عليها. هبدأ بالسيل سايكل انهبيشن عن طريق CDK4/6 inhibitors. ايه CDK4/6 inhibitors؟ cyclin dependent kinase type 4 type 6 inhibitor. Very briefly اي cell to go into cell cycle عندها check points عشان ما تدخلش into uncontrolled cell proliferation. التشيك بوينت المهمه قوي اللي هنشتغل عليها هي الجي 1 اس فيز. في الهرمون ريسبتور بوزيتيف بريست كانسر العادي ان الباثواي بتاعنا بيأكتيفيت حاجه اسمها سايكلين دي. السايكلين دي بيروح يأكتيفيت السايكلين دي CDK4/6 ودول مع بعض ده اسمه كاينيز، سايكلين ديبندنت كاينيز. كاينيز يعني حاجه بيأكتيفيت ازاي؟ بيروح ياخد الفوسفورس ويحطه على الريتينوبلاستوما جين. Actually what happens انه الريتينوبلاستوما جين ده ايه؟ ده تيومر سبريسور جين، فاكرين؟ تيومر سبريسور جين شهير. لما بنعمل كده الريتينوبلاستوما جين gets out of the picture والسيل بتدخل في السيل سايكل. يبقى السي دي كي ده CDK4/6 ده مشكله لانه بيليبريت التشيك بوينت، هو بيفك التشيك بوينت وبيسيب السيل تدخل في سيل ديفيجن. يبقى انا هانهبت CDK4/6 and that's how CDK4/6 inhibitors work. وهم كده مش peculiar قوي للبريست، هم كده شغالين على السيل سايكل، يعني هم مش بعيد قوي عن الكيمو. اوكي، لكن because of its very strong synergistic effect مع الانتي استروجينز او الهرمونال مانيبيوليشنز كان it was very appealing ان احنا نبدا باننا نبص عليهم في البريست، لكن هنسمع عنهم definitely in other solid tumors. خدوا ابروفل الاول في السكند لاين improvement في progression free survival في الثلاثه بالبوسايكلب رايبوسايكلب ابيمسايكلب، وبعد كده improvement في الاوفرول سرفايفل. وده في الفيرست لاين نفس الحكايه improvement في الاوفرول سرفايفل بس مع الرايبو وبي اف اس مع الثلاثه. سريعا بقى الباثواي اللي قلنا عليه PI3K AKT mTOR باثواي الاقدم في اللعبه هو الmTOR. كنا بنبدا باننا بنهبت الداون ستريم ده الmTOR، والmTOR ده داون ستريم بيأكتيفيت انجيوجينيسيس بروليفريشن وبيدخل في سيل سايكل زي ما كان باينه في اول دايجرام. عندنا ترايل واحده اللي هي البوليرو 2 ترايل، ودي عيانين كانوا بري تريتد باروماتيز انهبيتورز وحصل لهم ريزيستنس. سكند لاين كنا زمان بندي اكزامستين it is what we had. طيب نبص لو حطينا مع الاكزامستين everolimus هيحصل ايه؟ there was an improvement of progression free survival، لكن ما كانش فيه improvement في الاوفرول survival، ده understandable. يبقى it's a player، بس هو player رخم شويه هو وكل التارجتنج of the PI3K. البي PI3K اللي فوق بقى نطلع ده كده كان داون ستريم، ممكن نطلع فوق ونشتغل اب ستريم على البي PI3K انزيم نفسه اللي احنا قلنا انه 40% of the cases هو ده اللي فيه الميوتيشن ومشغل كل الاكسس. وعندنا دلوقتي ابروفل للالبيليزب PI3K inhibitor بناء على study اسمها سولار ترايل، كانت بتقارن ان انا ادي fulvestrant في عيانين beyond first line، ادي fulvestrant مع البيليزب ولا من غير البيليزب، وعشان يثبتوا قصه البي اي 3 كي كان في كوهورت متشخص ان عنده بي اي 3 كي ميوتيشن وكوهورت لا. superiority في العيانين اللي عندهم PI3K mutation اللي ما عندهمش no benefit whatsoever, so you have to do the mutation. مش كل حاجه بنعملها الميوتيشن خدوا بالكم، لكن هنا you have to do the mutation. ما عنديش حاجه يقيس بيها السي دي كي، ما عنديش حاجه يقيس بيها الام 2 لكن عندي حاجه يقيس بيها البي اي 3 كي. طيب انا I will wrap up very rapidly. دي اللي احنا قلناها في early breast cancer. Please remember you can in early breast cancer in early breast cancer you can use tamoxifen in all patients. You can use aromatase inhibitors only in postmenopausal patients or after inducing menopause in a premenopausal patient. طب في الميتاستاتيك breast cancer the theory still holds. انا اقدر استخدم تاموكسفين لوحده، لكن اي حاجه بعد كلمه تاموكسفين I have to do ovarian function suppression. والحقيقه الجايد لاينز هتلاقوها، ده واحده من الجايد لاينز NCCN هتلاقوها دايما بتحط لنا ovarian function suppression في سواء العيانه عندها visceral سواء العيانه ما عندهاش. الحقيقه يعني النهارده تقريبا ما فيش حاجه اسمها ان عيانه بريمينوبوزال ميتاستاتيك بريست كانسر بتتعالج من غير ovarian function suppression. اول حاجه بنعملها بنخليها مينوبوزال وبعد كده we can do whatever we want. الرير ايفنت ان انا ادي تاموكسفين لوحده في الديزيز فيري اندولنت العيانه اللي ما عندهاش مشكله مع التاموكسفين، الحقيقه ده تقريبا ما بنشوفوش لانه اصلا by virtue of ان البريمينوبوزال ديزيز is almost always more aggressive. فدايما think ovarian function suppression حتى لو هتدوا كيمو، دايما think ovarian function suppression. اخر حاجه بس كديفينيشنز بتسمعوها كتير في كل الكلينيكال ترايلز، في حاجه اسمها resistance والديفينيشنز دي تايم لاين ديفينيشنز فيري arbitrary ملهاش solid ground في البراكتس، هي بس natural history. احنا لقينا دول بيعملوا اوحش من دول. اوكي فالبرايمر الاندوكراين سنسيتيف هي عينه جايه من الشارع اغلب الوقت هرمون ريسبتور بوزيتيف اغلب الوقت هيكون سنسيتيف. هي دي اخر سلايد فما تقطعوهاش، اخر سلايد. اوكي فهي دي اغلب الوقت هتكون اندوكراين سنسيتيف. تمام. او عيانه كانت بتاخد ال5 سنين او ال7 سنين او whatever وقعدت سنه disease free، فدي by virtue of احنا متوقعين ان هي هرمون sensitive and you can have all the freedom انك تمانيبيوليت كل الهرمونال treatments. في عيانه على العكس خالص عندها primary resistance، يعني حصل لها relapse in the first 2 months of treatment وهي بتاخد adjuvant treatment، او ولو هي في الميتاستاتيك setting ما كملتش 6 months على الهرمونال تريتمنت قبل ما يحصل بروجريشن. ده برايمري ريزيستنس، ده ورست بروجنوزس، ده ما بيشتغلش فيه ناس كتير يمكن غير السي دي كي. اخر حاجه سكندري ريزيستنس هم كل اللي في النص، عيانه عدت السنتين بس ما خلصتش ال5 سنين وبعديها سنه، عيانه عدت ال6 شهور اندوكراين تريتمنت بس بروجريست. اوكي I just hope يعني انا حاولت المها. Thank you very much. I'm very sorry for being so much.
Thank you Dr. Shaima for the excellent presentation. I will proceed for Professor Ahmed Magdi. He will present principles of immunotherapy.
So thank you so much. So okay, now we have the presentation. Today I'm going to talk about basics of immunotherapy. So immunotherapy is using my immune system to fight cancer. We all know that our immune system can fight cancer, right? But there is a problem with our immune system, whether it's a DNA damage, whatever something affecting the immunity, which leads to progression of cancer. So is this a new thing? Actually, no. It was William Coley is suggested to be the father of immunotherapy. In the 1800s, by the end of the 1800s, he started treating cancer, and you can see the patient down there. He had a neck mass. So he discovered that when he injected bacterial toxins inside the tumor, actually the patient has improved and his tumor was gone. So something here he did, which is stimulation of our immune system, which attacked the cancer. So we have to know that our immune system is a very complex system. You all know that. And it has the ability to distinguish self-antigen from non-self-antigen. This is why we don't get normally autoimmune diseases. Because if our immunity does not detect my own system, it's going to start attacking it, leading to autoimmune diseases. So we have something called the innate immunity, which is the first line of defense. So whenever a bacteria goes inside my body, my immune system goes and attacks it. If it kills it, thank you so much, I don't need any further management. However, these are, so the innate immune system includes the mast cells, the neutrophils, macrophages, eosinophils, and natural killer cells. However, if the bacteria is too strong for my innate immunity, now it's time to get out the big guns. So if you look at the innate immunity here at the far left of the slide, you'll find that they do act within hours. So they are very fast in response. However, they are absolutely non-specific. If the bacteria cannot be managed, then I'm starting to call my big guns, the T lymphocytes and the B cells. But the problem is they take days. And here, the infection or the cancer gets the benefit of having days for our specific immune system to come out. So for the adaptive immunity, they are very highly specific. As I told you, we do have the humoral, the B cells, and the main commandos of our body, which are the T cells. Remember, our infection or fighting infection, fighting cancer, we need the most important, the strongest immune system or immune cell, which is the T cell. We all know the B cells, like from the famous acronym GAMID or MAGID, which is the IgG, immunoglobulin G, A, M, and ED. The beauty of the B cells are they are highly specific to the antigen. What do I mean by that? It strictly identifies the proper antigen and goes and attacks it. It doesn't need introduction by antigen-presenting cells like the T cells, which we'll see. The T cells, we do have 4. We have the CD4, which from the name it's called helper T cells. We all understand helper, it helps the CD8, which is the cytotoxic T cell. And then when I'm fighting the infection and I kill the infection, I need to suppress my immunity. So here comes out the T regulatory cells and the T memory cells, which suppresses my immunity back. I'm just mentioning basics because I'll show you that cancer uses these basics to avoid our immune system. So the dendritic cell, its main function is presenting the antigen to the T cells. So B cells, they go and attack directly the antigen. However, T cells need the dendritic cells to identify which antigen to attack. All what I just mentioned, which is the basics of our immune system, got those 2 gentlemen Nobel Prize in 2019, but they were talking about this in 1960, where we discovered that we do have something called the B cell and the T cells. Don't look at the left side and start by looking at the right side. This is the antigen presenting cell. It has something called the major histocompatibility complex, or the MHC, which puts the abnormal antigen and just presents it to the T cell. So the T cell, through the T cell receptor, identifies the peptide or the antigen and starts attacking this antigen. So any cell expressing this antigen will die. Then I need to suppress my T cell again, as I told you. So normally, if I overexpress the CTLA4 here, cytotoxic T lymphocyte antigen 4, it will lead to suppression of the T cell activity. Hold your thoughts about this. And then the dendritic cell, which is the antigen presenting cell, stimulates the T cell. However, if you look here, these are all used for stimulation or inhibition. These are all basics. I'm not talking cancer right now. Okay? What does the cancer do to avoid our immune system? So I showed you the basics. How do they avoid it? So first, they start by the major histocompatibility complex. They stop expressing it on the cell surface. So you cannot identify which antigen to attack. So the T cells are going blind. They don't know what to attack. And then overexpression of the CTLA4. So if they detect the antigen, they are suppressed. So the T cells cannot attack the antigen. Also, the PD-1, PD-L1 pathway, so activated cytotoxic T cells who are going to attack the cancer, the cancer understands quite well that if it overexpresses the PD-1 or the PD-L1, then it will suppress this attacking, cell. Also, cancer needs to feed, right? We all know that cancer needs blood supply. So they overexpress the vascular endothelial growth factor and interleukin-10, leading to neovascularization, and this is how cancer grows and metastasizes. how to overcome this resistance is whether you suppress the suppressing factors or you stimulate the stimulating effects. So it's either by vaccination, adoptive cell therapy, oncolytic virus, or the famous immune checkpoint inhibitors, which are gaining ground in oncology these days. What about the vaccines? We all know vaccines are one of the oldest immunotherapies have been used. So you get the antigen, you put it by injection, and you introduce it to the body. They understand this as a foreign body. So whenever you get the virus, your memory cells will kill it. And this is how we do the immunity. So here the dendritic cells are the main key players to introduce those antigens. So they thought of why, if we are succeeding in the vaccines against viruses and bacteria, why don't we try against cancer? So we get the antigen from the cancer and introduce it to our system. The problem was which antigen? Don't forget, cancer cell is a normal cell inside our body that do not obey order, that has a specific mutation. So they started looking at simple protein. And then when we inject it, it died. It did not do anything. And then if we added immune stimulants like the interleukin-2, again, we failed. Then they thought of, let's take the whole length of protein and not just specific protein. Again, we failed. Then they got the whole cell lysate, or the whole cell by itself, failed. And then they thought of, let's take out the dendritic cell, which are the antigen-presenting cell, introduce them to the antigen, stimulate them by immune stimulants, and putting them back inside the body of the patient. And actually, this is working in the prostate cancer. We all know the Ciplucil-T, which is used in advanced cancer prostate. However, it did not differ in anything but pain control only, no effect on progression-free survival, no effect on overall survival. What about oncolytic virus? We all heard about that the virus needs to go inside the cell because it cannot replicate on its own, and it needs the DNA of the host cell, right? So what if we educate the virus to infect only the cancer? So it goes inside the cancer cells, starting to replicate, killing the cancer cell. Did we succeed about that? We tried. So we got the tumor cell, we inject it with the virus replicates inside the cell, and the cell bursts and dies. However, when it infects a healthy cell, your immune system can kill it. The problem was, when we gave it to the patient, our immune system killed that virus. So the problem with that was to inject the virus specifically inside the tumor. For us in the clinics, sometimes it's very difficult to reach the tumor. You cannot even get a biopsy. So how to inject that? Did we succeed? Actually, there was the T-VEC vaccine, which succeeded in the melanoma. Why melanoma? We'll all listen about the immunotherapy in melanoma because it's highly immunogenic tumor. It has lots of mutations. What about the adoptive cell therapy? Adoptive cell therapy, we've all heard about them these days. So you do have, as I told you, the B cell are very highly specific that attacks specific antigen. And the T cells need a cell to introduce the foreign body. What if we can combine the B cell with the T cell and I produce a T cell that directly attacks the cancer? And actually, this was very successful in melanoma. And now in all the oncology, or now it's gaining ground, mainly in hematology, but now it's gaining ground in breast cancer, which was just mentioned the last ESMO this year in Paris, that now they are using the adoptive cell therapy in breast cancer. Why am I putting this picture here? Am I trying to impress you? Well, actually, this is called the chimera, which is in the Greek mythology. It's a creature combined of a lion, a goat, and a snake. So it's a mutation. So if I do that with the B cell and T cell, then I have the chimera, which is now called the CAR T cells, the chimeric antigen cells. And hence the name comes from there, from the Greek mythology, the chimera. Okay? So now I can produce a T cell that directly identifies the protein and goes and kill it, rather than needing an antigen-presenting cell which is suppressed by the cancer. It's very tedious, very expensive to do, So you extract the T cell and you do the genetic alteration of the B and T cell through identifying them with the cancer antigen and injecting it back to the patient. Hopefully it succeeds, and yes, it led to curability in acute leukemias. And now it has been used in myeloma, and for the first time, yes, it's not widely available, or I mean, it's not highly evidenced, but now we can say there is a cure for myeloma, or a potential cure for myeloma. Multiple myeloma is an incurable disease. Now we are just starting to talk that we can cure multiple myeloma. What about the famous immune checkpoint inhibitor gaining grounds? We mentioned that before, but we need to know, why do sometimes when you read about the risk factors for cancer, you find that chronic infection is one of the risk factors of cancer? Why? Because it leads to T cell exhaustion. So you're always producing T cells for the chronic infection, and they die, produce and die, produce and die. They're exhausted, so they don't come out again, or even they do not realize this chronic infection, because repetition of stimulation, they will pass by and see the chronic infection and say, okay, I know this is chronic infection, but this is cancer hiding in chronic infection. So the T cell receptor binding to the antigen, it's like the ignition key for the car. So for the T cell receptor to present the protein on the cell surface, it's actually turning the car on, which is the immune system. Binding of the proteins I showed you, binding of the proteins I showed you with the MHC, the B20, the B7 to the CD28 is the gas pedal, which increases the immunity and makes it strong and fast. However, cancer is very smart. It pressed the brake with two legs. So it stops the immunity by the CTLA4 and the PD-L1. So theoretically, if we can block the binding of the CTLA4 and the PD-1, PD-L1, then we might improve our immune system to detect cancer and kill it. Okay? And this, to tell you the truth, yes, this is the data now, and this is the new trend in oncology, but we're only talking about CTLA4 and PD-1. Now we're working on the TIM3, the BTLA, the VISTA, and the LAG3, and now we have already initial trials tackling those. So imagine if we can suppress all this, then cancer might die, and without using chemotherapy and only using our immune system. So if we do a comparison between chemotherapy, yes, I'm a medical oncologist, but chemotherapy is a stupid drug. It does not attack only cancer. It does attack normal cells and cancer cells. When we succeeded and we did the targeted therapy, we found that we can only attack a specific target. And now with the immunotherapy or the immune checkpoint inhibitors, we are using our immunity to kill cancer. Why do you combine it with chemotherapy? Sometimes we do see that we are combining immunotherapies with chemotherapies, because chemotherapy still does damage, and this damage releases more proteins in the blood, which are identified by our immune system, and then after I release the brake, I can succeed and kill this cancer. And it allows for more TILs, tumor-infiltrating lymphocytes. And this got another Nobel Prize. See, the oncology is having a lot of Nobel Prizes now. Those two, James Allison and Dr. Tasuku from Japan, they both got a Nobel Prize in 2018 because they discovered what I just mentioned, the CTLA4 and the PD-L1. We have a long road to detect in the immune system. And these are some. So I showed you the beauty of immune system, right? Now let's see the ugly face of the immune system. So the ugly face, first of all, we all can agree that it has a financial toxicity. And this was published in 2015 in Health Economics, that the US expenditure in 1 year on terminal cases, stage 4, was $174 billion. And if you're following the news today, you do the math. The dollar is 22.5 today. So please do the math and tell me. So what about the toxicity? Remember, we are releasing the brakes on our immune system. Our immune system has been suppressed for a long time. Now I remove the brakes. it's time for autoimmune problems. And what are the autoimmune diseases that we can have? You can start from the brain till the toes. Or anything autoimmune, something is vibrating very hard. Okay. So the conclusion, our immune system is the main player or the key player in defeating the cancer cells. Use your immune system by the immune checkpoint inhibitors. It's changing the landscape, and the first approval of immunotherapy was in 2011 with melanoma. In 2015 was the second approval in lung cancer. Now, more than 37 indications. Combination of different immunotherapies, it's very important, and yes, it's functioning, and it's very good. And now we can use a chemo-free regimen with only immunotherapy. And combining chemotherapy with immune checkpoint inhibitors, still today, even with the stupidity of the chemotherapy, it is a must to be added to immunotherapy in many of the cancer today. And thank you so much for listening. But one time.
مش عارفه مين اللي جاي اصلا مش عارفه مين. Thank you so much, Dr. Ahmed. Now with Dr. Iman Ali.
السلام عليكم. انا هحاول اكون تبقى ان شاء الله اخر محاضره، وان شاء الله تبقى محاضره صغيره باذن الله. We'll talk today. Yes. لا مش هحتاج. We'll talk today about the diagnosis and management of isolated axillary metastasis with occult primary breast cancer. Our case, she's female patient, 50 years old, premenopausal, ECOG1 with negative family history and past history. She presented to the clinic in August 2022 by right axillary mass. On examination, she had right fixed amalgamated axillary lymph node, 5 cm, no palpable breast lump, no palpable peripheral lymph node, or any other abnormality. She's clinical TX, clinical N2. She had bilateral breast sonomammography, showed bilateral normal breast study with evidence of right pathological axillary lymph node only. CT scan chest, abdomen, pelvis was free except for axillary lymph node. In such case, it is very important to evaluate the axillary lymph node. The axillary lymph node should be discriminated from the primary breast tumor located in axillary tail by sonomammography. Biopsy taken from axillary lymph node, it's proved metastatic adenocarcinoma, considered ductal origin. Bone scan, labs, echo was free. Now we have a case of isolated axillary metastasis without evidence of the primary breast cancer. Such a condition, the commonest cause of such diagnosis in female, it was ipsilateral breast cancer. Such diagnosis was seen in less than 1% of newly diagnosed breast cancer cases in the clinic. It is a rare entity. Away from the breast cancer, we have many other malignancies could be metastasized to the axillary lymph node, like lung cancer, lymphoma, melanoma, thyroid cancer, colorectal carcinoma. The careful history and the clinical examination and the core biopsy is very important. If the core biopsy is negative, we have to go for excisional biopsy. Now we have a case of isolated axillary metastasis with occult primary breast cancer, as evident by breast sonomammography and CT scan. What we have to do to diagnose this patient? Number one, pathology. The histopathology examination and the immunophenotyping is very crucial and mandatory in such cases. The hormone receptor ER, BR, HER2 is very helpful. If we have positive ER and BR, it indicates a very strong evidence for the breast origin. But actually it was positive only in 50 to 60% of the cases, while if we have negative ER, BR, does not rule out the primary breast origin. It was present in about 30% of the cases. As well, we can see positive ER in other malignancy like melanoma and renal cell carcinoma and colorectal cancer. So the other immunophenotyping in such cases is very important, like CK7, CK20, GATA3, CA, but none of these markers individually can make definite diagnosis of the breast cancer. As we see in this figure, the different expression profile of cytokeratin 7 and cytokeratin 20 can help to differentiate between a very wide range of malignancy and histologies. if we return back to our case, she had immunophenotyping, it showed ER with weak positive 10%, BR was negative, HER2 was negative, CK7 is strong positive, GATA3 is positive, CK20 was negative. So the final diagnosis, it is a case of metastatic adenocarcinoma of the breast origin, although we have ER, BR, HER2 was negative. Now, again, we have a case of isolated axillary metastasis with pathological evidence of metastatic adenocarcinoma of breast origin with negative breast sonomammography and CT scan. Do we need further investigation for such a case like PET-CT, contrast enhances mammography, post-contrast MRI breast? The sonomammography sensitivity in such cases, it is only 47 to 64%, which is go less if we have a dense breast. A study of mammographic diagnosis of occult primary breast cancer showing that there is more than 30% of the cases detect primary breast cancer malignancy after mastectomy. In historical data, we have more than 80% of sonomammographic diagnosed occult breast cancer then had a primary breast cancer in mastectomy specimen as well. While the MRI breast can identify the primary breast lesion in more than 70 to 80% of mammographic negative occult primary breast cancer. The MRI breast is not important only for diagnosis. No, the MRI breast is important as well for prognosis, because the study that for the studies we did not use the routine MRI breast, there is increased the incidence of ipsilateral breast cancer to reach 25% of the cases versus only 9% of the cases in the study that use the MRI breast as a diagnostic modalities. So the MRI breast is a diagnostic image of the choice of such cases. It can help as well to facilitate the decision for breast conservative surgery. So if we want to define isolated axillary metastasis with occult primary breast cancer, we need histological evidence of axillary metastasis of the primary breast origin, and we need negative MRI breast as well. What about the contrast enhanced mammography and PET scan? Both modality can be used. It could be an option, but with very limited data about the routine use in such cases, but could be used. Now, we have a case of clinical TX, clinical N2, triple negative breast cancer like with occult primary breast cancer as evident by negative MRI breast. What about the management? What about the systemic treatment? What about the local regional treatment in such case? Would you go for axillary clearance only, or axillary clearance with ipsilateral mastectomy, or axillary clearance with upper outer quadrectomy and post-operative radiotherapy, or axillary clearance with ipsilateral whole breast radiotherapy? The systemic treatment should be offered for such case as the same as a guideline to treat stage 2 and stage 3 breast cancer, and according to the molecular subtype, being triple negative HER2 positive luminal disease, will treat this patient being stage 2 and stage 3 breast cancer. But what about the optimal local regional treatment? We have a big dilemma about this point. The data for the local regional treatment in such cases is very limited and depend only on small number of retrospective study, meta-analysis, case series with selective bias and a small number of the patient. At the same time, we don't have any randomized phase 3 control trial to clear or to justify the clear guideline to treat such cases. Here I will express some case series and some data about the treatment plan for such patient. One case series published by MD Anderson, including only 45 patients, published in 2001, in which 29% of the cases had axillary lymph node dissection with mastectomy, and 71% of the cases had axillary lymph node dissection with ipsilateral whole breast irradiation. This case series showing there is no any significant difference as regard local regional recurrence, distant metastasis, and overall survival between ipsilateral radiation or ipsilateral mastectomy. Another recent meta-analysis including 241 patients from 7 publications. This meta-analysis including divide the patient in 3 groups. First group, patient underwent axillary lymph node dissection with ipsilateral whole breast irradiation. Second group, axillary lymph node dissection with ipsilateral mastectomy. Third group underwent axillary lymph node dissection only without any directed treatment to the ipsilateral breast. This meta-analysis highlight or give two important answers. First one, there is no any statistical significant difference as regard the local regional recurrence or distant metastasis or overall survival in patient who underwent axillary lymph node dissection with ipsilateral mastectomy versus axillary lymph node dissection with ipsilateral whole breast irradiation. The second information that the patient who received ipsilateral breast irradiation showing significant improvement of local regional recurrence and trend toward decrease the mortality as well in patient who received ipsilateral radiotherapy versus the patient who did not receive any directed treatment to the ipsilateral breast. In such a meta-analysis, the ipsilateral recurrence in patient who did not receive any direct treatment to the ipsilateral breast, it was reached 34% versus 12%. The last one, it was a multicentric retrospective study by South Korea, including 66 patients, including patients with isolated axillary, supraclav, internal mammary lymph node metastasis with occult primary breast cancer. In such a study, all patients had chemotherapy, had anti-HER2 treatment according to HER2 status. All patients had negative MRI breast, and all patients received ipsilateral whole breast radiotherapy plus or minus regional nodal irradiation. The median follow-up of all patients, it was 82 months. This result showing this very good local control for such a patient to when be treated by ipsilateral whole breast radiotherapy, in which the 5 years overall survival, disease-free survival, breast cancer-free survival of all patients was 93, 92, 96% respectively. And this study showing as well the incidence of ipsilateral breast recurrence, it was only 9%. And the most important negative prognostic factor, it was the number of involved lymph node and the nodal stages like internal mammary lymph node or supraclavicular lymph node involvement. So to summarize, the isolated axillary metastasis with occult breast primary is a rare entity. MRI is the diagnostic image of the choice. Histopathological examination and immunophenotyping with clinical examination is crucial. Systemic treatment should be offered as a stage 2 and stage 3 breast cancer and according to the molecular subtype. In all series, the ipsilateral mastectomy and with axillary clearance was the treatment of choice. Maybe in all series, the sonomammography was the diagnostic modality with increased detection rate of the primary breast cancer in the mastectomy specimen, which may explain or he maybe give a justification why in the old series the ipsilateral mastectomy was advised, because there is increased incidence of increased ipsilateral breast recurrence if the patient had breast conservative surgery. But with recent series, the mastectomy was not necessary. Although we have limited data with small number of patients, the ipsilateral whole breast radiotherapy with axillary lymph node dissection offer a reasonable treatment option for such cases with comparable local regional control and overall survival, provided we have a routine MRI to confirm the absence of the primary breast cancer. لاست سلايد يعني قعدت ادور على جايد لاين ان احنا نتحط للناس ديت، فلقينا ان ال NCN جايد لاين فيرجن 4 2022 had a comment about the isolated axillary metastasis with negative with occult primary breast cancer. في ال NCN جايد لاين هم بيشترطوا ان العيانين دول should had MRI breast، وحطوا التريتمنت اوبشن فور MRI نيجاتيف كيسز باي according to the nodal status. البيشنت اللي هم TXN1 العيانين دولت we have the two option to be treated، يا اما اعمل لهم axillary lymph node dissection with ipsilateral radiation او ان انا اعمل لهم axillary lymph node dissection with ipsilateral mastectomy. لكن العيانين هو presented to by TXN2 N3 بنديهم نيو adjuvant treatment according للموليكولار بروفايل بتاع العيانه followed by هنا followed by axillary lymph node dissection and mastectomy as the patient with locally advanced disease. They recommend for systemic chemo, endocrine, and anti-HER2 is given according to the recommendation of stage 2 and 3 breast cancer. Thank you.
Thank you very much, Prof. Dr. Iman. And now we'll proceed with the symposium with our dear professor, Professor Amani Hilal.
قولي حمدي. ده ايه بقى؟
مساء الخير عليكم جميعا. Thank you very much for joining us in the 5th Bahia Breast Cancer Conference. Thank you, Chairperson, for the nice introduction. Presentation about a very old drug we all be familiar with. So I think the data is just to remind ourselves, or just to refresh our knowledge after the very big knowledge of the immune therapy and the target therapy and so. Docetaxel in breast cancer, we all know that breast cancer is the second most incident cases for both sexes and all ages in Egypt, and it is the most common cancer affecting females worldwide, not only in Egypt. Docetaxel is made from the bark of the Pacific yew tree, so it is a semi-synthetic product, and it acts by stabilize the microtubules, interfering with the cell division and ending with apoptosis. It's an M-phase specific drug, together with the paclitaxel and the cabazitaxel. Docetaxel in early breast cancer, we all know the systemic treatment in the early breast cancer, including chemotherapy, hormonal treatment, target therapy, and immune therapy. I was introducing this slide maybe 3 years ago, and there were no immune therapy in the early breast cancer. Nowadays, it's introduced in the new adjuvant treatment of the triple negative. Going very back, chemotherapy versus no chemotherapy, and this question we are asked in every clinic. Why a patient underwent operation and she is cleared now from the tumor, is receiving chemotherapy? Because we have a meta-analysis including more than 100,000 women, showing us that the addition of the chemotherapy in the early breast cancer improves the 10-year recurrence-free survival about 8%, and the 10-year overall survival by 6.5%. And the next step was to give anthracycline or non-anthracycline, and again anthracycline added to the survival benefit about the 4% in the overall survival and 2.6% in the disease-free survival. Going more forward, and with the addition of the taxane to the anthracycline-based chemotherapy, the taxane showed the improvement in the recurrence-free survival by 4.6%, and in the overall survival by 2.8%. So over the years, we are getting improvement in the survival of the early breast cancer only by adding chemotherapy, then anthracycline, then taxane. With the addition of the target therapy to the HER2 positive, of course, we have a very good the improvement in the survival. Now, when to give the chemotherapy, we all know that in the early breast cancer, whether to give adjuvant after the treatment, or neoadjuvant after the surgery, or neoadjuvant before surgery. And the neoadjuvant chemotherapy is the basic for the research in the medical oncology department. You are giving a treatment to the patient, and you can see the response, whether the patient is responding, not responding, progressive. So the neoadjuvant, I think it is the base for the research. It's very important mode of treatment. PROS is allows direct observation of response. PCR is a surrogate for prognosis, and knowing the pathological response added to the treatment decision after the operation. Many patients still not candidate for breast conservative surgery, still even after neoadjuvant treatment, and no standard for chemotherapy modification for poor responders, and PCR is not prognostic in all biological subtypes. So what is the role of the taxanes in the neoadjuvant chemotherapy? We all, when we are giving a patient a neoadjuvant, we are searching for, or pushing the patient into the pathological CR. Adding the taxane over anthracycline in the neoadjuvant setting in this meta-analysis of 16 randomized clinical trials, including more than 6,700 patients, showed the improvement in the pathological complete response, and the improvement in the disease-free survival, and significant improvement in the local regional recurrence-free survival. However, the addition of taxane to the anthracycline showed no significant impact on the rate of the breast conservative surgery or the overall the survival. So adding taxane, whether paclitaxel or docetaxel, to the anthracycline improved the pathological CR, what we are all searching for when we are giving the patient a neoadjuvant treatment. This is the association between the PCR and the event-free survival. Why the PCR is very important? As you can see, it is important in the HER2/neu positive mainly and the triple negative, and also in the hormone receptor positive, but the association is not that strong as in the other biological subtypes. Now about the schedule of the adjuvant the chemotherapy, this is a very old trial, trial trying to, after 4 cycles of the anthracycline cyclophosphamide, the patients were randomized into paclitaxel every 3 weeks, and this was the standard to be compared by paclitaxel weekly, docetaxel every 3 weeks, and docetaxel weekly, and the outcome is that giving paclitaxel weekly and docetaxel every 3 weeks is the superior to the other regimens, and that's why they are now the adapted regimen for the adjuvant treatment is whether to give paclitaxel weekly or the docetaxel every 3 weeks. Actually, very early in the trial, there were a difference in the overall survival, but with the longer follow-up, this schedule of a treatment only form a change or the improved the disease-free survival, which is a very good outcome also. With I know the most common used the adjuvant regimens are the anthracycline followed by taxane, but we have the subgroup of patients in which anthracycline is not a suitable drug, as those with the cardiac toxicity, as the old population which cannot tolerate the very toxic treatment, those patients with the good risk disease, lymph node negative but high risk that do not require this very long treatment schedule. Comes up the regimen of docetaxel with cyclophosphamide, which is associated with improvement in the overall survival and disease-free survival over the 4 cycles of AC. It's not compared with the AC followed by taxane, but at least it is superior to the 4 cycles of the anthracycline and the cyclophosphamide. Was a tolerable regimen in both older and younger patients. There is another trial I didn't put here, trying to test for docetaxel cyclophosphamide in older population, 70 years, and actually it is very tolerable with a very good precautions, of course. Okay. So look to the NCCN guidelines for the preoperative or adjuvant therapy for HER2/neu negative. Here comes the favorable with the TC docetaxel cyclophosphamide and the other recommended regimens AC followed by docetaxel. For the role of docetaxel in combination with the trastuzumab, I'm sure you all know this trial of the BCIRG when we tried to omit the anthracycline from the adjuvant treatment of the patients with HER2/neu positive breast cancer, because we are adding to the cardiac toxicity, adding trastuzumab to the anthracycline, add to the cardiac toxicity. So they tested the use of the non-anthracycline regimen of docetaxel and carboplatin, and there is they are almost approaching the effect of the using anthracycline followed by the docetaxel trastuzumab, and both were superior to the non-use of trastuzumab in HER2/neu positive, which is not accepted, of course, nowadays. Trying to find if the use of the anthracycline is useful in the high-risk population over the combination of the docetaxel carboplatin. This is the subgroup analysis showing the overlap of the 2 curves in patients with the more than 4 positive lymph nodes and the patients with the general positive lymph nodes. So the TCHB now is considered the favorable for the treatment of the patients with HER2/neu positive breast cancer. This is the most common toxicities with the combination of the ACTH or TCH, and as you can see, the non-hematologic toxicities are lower among the non-anthracycline group. The most important is the cardiac toxicity. The cardiac toxicity is much lower with the TCH chemotherapy regimen when compared to the ACTH. And again, with the guidelines, HER2/neu positive, TCH is the favorable, TCHB and other regimens that can be used is only AC followed by docetaxel trastuzumab. Now, docetaxel in metastatic breast cancer, of course, I can't find all of the trials, the testing for docetaxel in the treatment of the metastatic breast cancer, so I choose the 2 trials. This trial showing survival outcome and cost effectiveness with docetaxel and paclitaxel in patients with metastatic breast cancer. It was a population-based evaluation, included more than 400 the patients. The patients were eligible for this study if they were treated with paclitaxel at 175 milligram per square meter every 3 weeks, or docetaxel at 100 milligram per square meter every 3 weeks for metastatic breast cancer after failure of the anthracycline-based chemotherapy. And this is the general the guidelines we are going with. If the patients failed anthracycline, we can pass to the second step with taxane. Median overall survival of docetaxel was 10.9 months versus the 8.3 months for the paclitaxel. The toxicity of paclitaxel, of course, was the lower than that they reported for the docetaxel without the major impact on the mortality. This is a meta-analysis of phase 3 trials of docetaxel alone or in combination with chemotherapy in metastatic breast cancer, and significant reduction of the risk ratio was found in the time to treatment progression, but not in the overall survival when the patients were treated with the single agent docetaxel compared with the combination of docetaxel and the other chemotherapeutics, which raising the our awareness that a single agent docetaxel could be beneficial for the patients without adding to the toxicity to the patients with metastatic disease, unless we needed this for patients who needed a very rapid response. This is the overview of the Advanced Breast Cancer 5 guidelines. So if the patient is with the visceral crisis, pre or the perimenopausal for hormone receptor positive, of course, if not in visceral crisis, hormonal treatment is the gold standard. But if the patient is presented with visceral crisis, then the patient should go for the chemotherapy, usually starting with single agent, and usually you go with anthracycline, then taxane, or start with the taxane from the start. These are the NCCN guidelines for the metastatic invasive breast cancer, the HER2 negative. The anthracycline comes first, and then the taxanes for the management of patients with metastatic disease. Docetaxel advanced HER2 positive breast cancer. It is the cornerstone in the management of patients with metastatic HER2 positive, as the BioCleopatra trial, which compared the docetaxel plus trastuzumab versus docetaxel plus trastuzumab and pertuzumab. And of course, we all know that additional pertuzumab added to the survival for the patients with metastatic HER2 positive, but docetaxel is the backbone of the both regimens. And these are the NCCN guidelines. Side effects of docetaxel: hematological toxicities, neutropenia and febrile neutropenia occurring in about 18% of the patients received a dose of 100 milligram per square meter, and this can be prevented by the prophylactic use of the granulocyte colony stimulating factor. And this is the non-hematological toxicities in the patients with the docetaxel. The most important is the hypersensitivity reactions and the fluid retention side effects, and these can be prevented by careful pre-medication with these steroids. Usually adding these steroids can prevent up to 30% of the fluid retention complication. Also the skin complications, nail complications, we all know about the side effects of the docetaxel. The main problem with the treatment expenses is the expenses, especially patients with metastatic disease who are giving the treatment until the patient is progressed or is intolerant. And one of the methods to guard against expensive drug is to use the generics. The generics are defined as the chemically identical couples of older drugs that have lost patent protection. Of course, these generics cost less and cost less for the company and cost less for the patients. A very known method of the guard against the high expenses, and this FDA study showed that generic competition is associated with the lower drug prices. So chemotherapy is still the backbone for the treatment of the breast cancer. Docetaxel is one of the essential and effective drugs in the treatment of wide variety of cancers, including breast cancer. Docetaxel has a crucial role in both early and metastatic disease, is well-tolerated drug with manageable side effects and good precautions. Old is gold. Thank you very much.
Ramani, for your elegant talk.